Sentiamo Ugo. Scusate, iniziamo. Professor Boggi, iniziamo? Okay. Good afternoon. We are now starting our section on pancreatic surgery, but just before there is a presentation from...
Yes. Good afternoon. Thank you. Please, Dr. Vaglini will have a speech on the displays and please.
Buonasera a tutti. I miei ringraziamenti vanno decisamente al professor Boggi, al caro amico Ugo, ci conosciamo da una vita. Mi ha invitato qua perché al termine di questo incontro darete una pergamena. Questa pergamena è l'atto di fondazione del nostro ospedale di Pisa. Prima di iniziare a dire due parole su questa pergamena, su questo contesto di questa location, permettetemi di portare i saluti del presidente, professor Gianni Iacovelli, dell'Accademia di Storia dell'Arte Sanitaria, che ha sede a Roma, presso l'ospedale Santo Spirito in Sassia, e gestisce il Museo di Storia della Medicina. Io ne faccio parte da una vita e dirigo un centro interregionale per la documentazione bibliografica e archivistica biomedica. Non so quanti di voi conoscano l'Accademia o ne abbiano sentito parlare, ma certamente un po' in altri ambiti, come l'Accademia dei Lincei, l'Accademia della Crusca. L'Accademia ha fatto quest'anno 100 anni, fu fondata dal professor Capparoni 100 anni fa. Bene, allora, questa pergamena, l'originale di questa pergamena è andato perso. Non è stata più trovata, come in tanti casi di questi oggetti, capita spesso, no, di perderli. E io ho ritrovato il testo in un codice qui all'Archivio di Stato di Pisa, molto bello, manoscritto, e l'ho rimessa su pergamena. Non ne ho mai consegnate se non in un numero limitato a persone che sapevo a cui tenevano a questo documento. Brevissimamente dico, a volte mi chiedo, da storico della medicina e da filologo medico, dico, ha senso oggi parlare ancora di storia della medicina? O è solo curiosità aneddotica? Voi oggi fate esperienza. Sono pochi, sono tanti. Io credo che tra il testo di questa pergamena e il congresso che avete in corso voi oggi ci sia un punto importante di contatto, l'aiuto alle persone che hanno bisogno, l'aiuto ai malati. Bene, la malattia nel Medioevo, quando è stato fondato il nostro ospedale, aveva un altro concetto rispetto a quello che ha oggi, ma l'aiuto ai bisognosi è sempre lo stesso. È qui che io credo sempre di trovare una connessione nelle nostre radici storiche. Quando uscirete di qua vedrete l'antico ospedale ormai Santa Chiara, antico ospedale di Santa Chiara, che ha una bellissima storia, ma non lo dico da pisano, perché il nostro ospedale ha una storia che è conosciuta in tutto il mondo. Di fronte, ora, in via Santa Maria, c'è un altro ospedale, quello che oggi è tutto tappato, no, da quell'armatura, e quello era l'ospizio, un altro ospedale, l'ospizio dei Trovatelli di Pisa. Spero entro l'anno di tirar fuori questo mio studio sulla storia di questo ospizio. L'unione dell'Ospizio dei Trovatelli e del Santa Chiara ha dato origine a quelli che sono stati i nostri ospedali riuniti di Santa Chiara. Ospedali riuniti che nascono come istituzione alla fine del Settecento, ma l'ospedale di Santa Chiara appunto ha una storia lunghissima, che ovviamente qua non vi sto a raccontare. Però vorrei dire soltanto una cosa, e poi vi lascio ai vostri lavori. Quando io mi occupo di storia della medicina, spesso noi storici cosa facciamo? Parliamo dei grandi medici, dei grandi presidenti che hanno gestito la sanità, delle persone più eccellenti, ma ci dimentichiamo sempre dell'attore principale, cioè il malato. Quando io ho pubblicato per la prima volta la storia del Santa Chiara, ho voluto dare spazio ai nomi dei malati che nel 300, cioè all'inizio del 300, erano presenti, erano ricoverati qui nel nostro nosocomio. A quel tempo, non so se avete avuto opportunità o se avrete opportunità di andare a visitare il Museo delle Sinopie, l'attuale Museo delle Sinopie, molto bello. Se non l'avete fatto, fatelo. Quella era la corsia più antica dell'ospedale. E fate attenzione, perché dietro le sinopie ci sono degli incavi che erano, potremmo dire, i comodini dei malati dell'epoca. Quelli sono rimasti intatti. Le persone che erano ricoverate. E ho visto persone che venivano da Genova, da Bologna, da altre città d'Italia. E non tanto perché l'ospedale di Santa Chiara era sulla famosa via Francigena, ma perché aveva già una rinomanza, aveva già una fama nazionale di validità del nosocomio. A quel tempo non c'era il Servizio Sanitario Nazionale, non c'erano i finanziamenti pubblici. E dove trovavano tutte queste forze anche economiche per gestire l'ospedale? Ecco, io vorrei un po' sfatare la storia dei grandi nomi, ma rivolgermi a quelle suore oblate di Santa Chiara, che oggi sono in un angolo in via della Faggiola, ma che per prime hanno finanziato, per credenza, per convinzione, per fede religiosa, finanziato questa struttura. Davano tutti i loro possedimenti per poter costruire un qualcosa di concreto e di operativo. Sono le persone più, diciamo, meno note, ma che credo che siano importanti invece, una volta tanto, dare spazio nelle nostre memorie, nei nostri ricordi anche a loro. Bene, io dico buon lavoro a questo incontro, è un incontro che mi fa sapere parlare di 20 anni di robotica, chissà, fra 100 anni, come oggi noi diciamo, i ferri chirurgici, guarda che ferri chirurgici erano quelli, mamma mia, fra 20 anni diranno, ma guarda qui, fra 200 anni, che oggetti usavano per fare la robotica. Va bene, ma questa è l'evoluzione della scienza. E credo che sia importante, le case si costruiscono dalle fondamenta. Quando si va verso il futuro, non dimentichiamo mai le nostre radici storiche. Buon lavoro a tutti.
Grazie veramente per questa presentazione. Non so quanto possa essere utile, ma io sono romano e l'Accademia è ben conosciuta a Roma e Santo Spirito in Sassia è un punto di riferimento per diverse attività. Grazie a lei.
Mi fa estremamente piacere. Buon lavoro.
Grazie. So we are going to start with 3 presentations. No one of the presenters will be here, but we have it's just the opportunity to share the international experience and just to have a vision of the pancreatic surgery. So we will discuss about the surgery of the pancreas, that is the most difficult task, and then for the resection of the tail of the pancreas, and of course, having a vision, a look at the implementation of this kind of surgery by the robot. So we will start with the safety and efficacy of the robot-assisted versus open pancreatic duodenectomy. The meta-analysis will be presented by Wei Zhang of the Beijing University of China. So we have to wait the connection.
We're going to introduce a meta-analysis of multiple worldwide centers regarding the safety and efficacy of robot-assisted versus open pancreaticoduodenectomy. The first pancreaticoduodenectomy was reported by Giulianotti in 2003. The robotic system offered some advantages, such as the magnification of the operative field and the usage of endowrist instruments capable of performing scaled movements and eliminating tremor. Nevertheless, in this presentation, we are going to introduce a meta-analysis of multiple worldwide centers regarding the safety and efficacy of robot-assisted versus open pancreaticoduodenectomy. The first pancreaticoduodenectomy was reported by Giulianotti in 2003. The robotic system offered some advantages, such as the magnification of the operative field and the usage of endowrist instruments capable of performing scaled movements and eliminating tremor. Nevertheless, the safety and effectiveness of this robot method have not been fully determined. The aim of this meta-analysis is to evaluate the safety and efficacy of robot-assisted pancreaticoduodenectomy and open pancreaticoduodenectomy in the treatment of pancreatic diseases. Regarding the safety and efficacy of robot-assisted versus open pancreaticoduodenectomy. The first pancreaticoduodenectomy was reported by Giulianotti in 2003. The robotic system offered some advantages, such as the magnification of the operative field and the usage of endowrist instruments capable of performing scaled movements and eliminating tremor. Nevertheless, the safety and effectiveness of this robot method have not been fully determined. The aim of this meta-analysis is to evaluate the safety and efficacy of robot-assisted pancreaticoduodenectomy and open pancreaticoduodenectomy in the treatment of pancreatic diseases. The search terms used for the meta-analysis were open or laparotomy and pancreaticoduodenectomy or pancreatectomy, and robotic or robot-assisted on PubMed, Medline and Cochrane Library until May 2020. We included reports of patients undergoing pancreaticoduodenectomy, including comparative analysis of various indicators of the two surgical methods, regardless of the sample size and the length of follow-up. The considered indicators were operation time, estimated blood loss, wound infection rate, reoperation rate, hospital stay, intraoperative transfusions, post-operative pancreatic fistula, and clinical post-operative pancreatic fistula, R0 rate, retrieved lymph nodes, overall complications, bile leakage rate, delayed gastric emptying, 90-day mortality, and severe complications. The exclusion criteria were lack of complete information or possibility to extract data correctly, studies regarding non-robotic surgery or non-pancreaticoduodenectomy reviews, case reports, or animal experiments. The quality of selected studies was evaluated using the Newcastle-Ottawa scale with a maximum score of 9 stars. Meta-analysis was conducted using relative risk for binary data and weighted mean difference for continuous data. Heterogeneity among reduced studies was evaluated using I-squared. When I-squared was greater than 30%, a random effect model was applied. Publication biases were evaluated using funnel plot, Beggs, and Eggers tests. Regarding the results, starting from 372 records, only 25 studies were included in the qualitative synthesis and only 18 in the meta-analysis. Of these, 11 were from prospective database and 7 from retrospective database, for a total of 5,795 patients, 1,420 robotic, and 4,375 open. 15 post-operative outcomes were evaluated as reported in this table. To note that a subgroup analysis taking into account the type of study, retrospective, prospective, or with propensity score match, was performed too. Operative time was significantly longer for robotic pancreaticoduodenectomy, especially in retrospective studies, p equals 0.08. The mean difference was 80, using the random effect method due to the high heterogeneity. Estimated blood loss was significantly lower for robotic pancreaticoduodenectomy in both retrospective and prospective studies. As for the intraoperative blood transfusion, to note that the heterogeneity for this outcome was intermediate and it reduced to 0% if Chi study was eliminated. Otherwise, there was no significant difference in terms of post-operative stay between the two groups. But if the analysis were limited to retrospective and propensity score match studies, the length of stay would be statistically shorter in the robotic group. There was no significant difference for retrieved lymph nodes too, both for retrospective and prospective studies. Instead, the R0 rate was significantly higher for robotic pancreaticoduodenectomy, even if there were no differences considering the different types of study separately. Regarding overall complications, there was statistically significant difference in favor of robotic approach after removing Macmillan study in order to obtain a drop of the heterogeneity to 33%. Also regarding clinical post-operative fistula, the outcome was statistically significantly better for robotic approach, both for retrospective, prospective, and propensity score match studies. And the same figure is for wound infection rate and reoperation rate. Otherwise, there were no differences for bile leakage rate, for severe post-operative complications, post-operative pancreatic fistula, and 90-day mortality rate. For delayed gastric emptying, there were no differences in the overall analysis too, but considering only the prospective studies, the outcome was significantly better in the robotic group. This study has some limitations. Most of the studies included are retrospective. Robotic pancreaticoduodenectomy is a complex process and is still in its infancy, so the number of cases in each study is small, and some studies reported on data obtained during the learning curve. Anyway, despite some limitations, this meta-analysis showed that robotic pancreaticoduodenectomy is superior to open pancreaticoduodenectomy in terms of R0 rate, infection of the wound site rate, reoperation rate, length of hospital stay, blood transfusion rate, and clinical post-operative pancreatic fistula rate. Instead, the operation time is longer than in the open approach. So in conclusion, robot-assisted surgery is a safe and feasible alternative to open pancreaticoduodenectomy, especially with regard to short outcomes. This needs to be further verified by high-quality clinical trials.
The next, we'll discuss all the presentations at the end. The next presentation is on robotic distal pancreatectomy, is from Dr. Polanco. Dr. Polanco recently moved from Pittsburgh to Southwestern University in Dallas together with Dr. Zhe. And in the Southwestern Center in Dallas is becoming one of the most active centers in pancreatic surgery in the last years, and it will be interesting to listen from him, his opinion on a robotic distal pancreatectomy.
Good evening. My name is Patricio Polanco. I'm an associate professor of surgery and director of the Robotic Surgery Training Program in the Department of Surgery in the University of Texas Southwestern in Dallas. I want to thank the Italian Society of Surgery and specifically Dr. Ugo Boggi for the kind invitation to present this topic titled State of the Art of Robotic Distal Pancreatectomy. This slide depicts our NCCN Comprehensive Cancer Center in the top right and our main university hospital in the lower left, where we perform our robotic procedures. To frame today's topic, I would like to start saying that minimally invasive distal pancreatectomy has been reported to be associated with shorter length of stay, reduced blood loss, and lower morbidity. Because of these findings, minimally invasive approach has become the standard of care at most experienced high-volume pancreas centers in the United States. The role of robotic distal pancreatectomy continues to evolve and increase as more hospitals adopt this technology and more surgeon centers report their outcomes. Yet, there's lack of prospective trials for robotic distal pancreatectomy but plenty of retrospective data regarding safety and feasibility of this approach. Today, we'll take a closer look to some of this data. First, I would like to discuss indications. In our institution, the most common indications for robotic distal pancreatectomy include mucinocystic neoplasms, main duct or branch duct IPNM with high-risk features, large pancreatic neuroendocrine tumors, functional neuroendocrine tumors not amenable for inclusion, and pancreatic adenocarcinoma. This has been shown to be safe in experienced centers with adequate expertise and when surgeons have overcome the learning curve. Yet, it's still a matter of debate, and there's pending ongoing clinical trials regarding this topic. Relative contraindications, as we described, are major vascular involvement, need of multivisceral resection, and big, bulky masses. The reason why we describe this as relative contraindications is because we truly believe that relative indications or contraindications of any procedure in general are highly influenced by surgeon's expertise and comfort level. Even if a randomized trial shows you that this or that approach is beneficial for the patient, it will only matter if the surgeon is actually proficient in performing that particular surgery. I'm going to briefly review the technique for our robotic distal pancreatectomy. This has been described in the past, but we also included in this manuscript. First, the robotic setup on the left. This is a setup in the operating room when we were using mainly the SI system. As you probably know, with the XI system, we can dock a robot from any side. When the S side, the robot was being docked over the head of the patients. These are robotic trocar placement. We mainly use 4 robotic trocars. The assistant ports are optional depending on the complexity of the case. Meaning, if we're going to perform a vascular resection or reconstruction, if we're going to need an extra hands of a staple, or if we're going to need a liver retractor to lift up a bulky left liver that is leaning over the stomach or the distal pancreas. But this is the standard approach that we use in our institution. Regarding the steps of the procedure itself, first, as you probably know, and this is, I'm going to go quickly through this portion as this is pretty standardized among most institutions. First, we have a revision of the gastrocolic ligament and the short gastric vessels. Followed to this, as we expose the anterior aspect of the pancreas, we perform routinely intraoperative ultrasound to better identify the tumor and map out the area of transection. We then try to identify via ultrasound and also through the robotic ultrasound probe the splenic artery location, and we circumferentially resect the artery here and later divide it with vascular load. Many surgeons prefer to suture like ABs, others like to clip it. In our institution, we prefer to use vascular staples, whether these are laparoscopic from the assistant port or robotic vascular loads. We then proceed with a circumferential dissection of the pancreas and neck or body, depending on the level of transections, and then we divided it with a linear staple as well. We have tried different approach with different color or thickness of staple loads, as well as oversawing the stumps. We have not found any difference regarding the leak rate. Yet, if we're dissecting the neck and we're really close to the GDA that we want to preserve, often we divide this with robotic monopolar scissors and then oversaw it with a barbed suture of V-lock. Later, we dissect the splenic vein. Often we dissect the vein first before we divide the pancreas, but this is a matter of preference and also a matter of what is the actual presentation when we're dissecting this area. We circumferentially dissect the splenic vein and also divide it with a vascular linear load. Then we proceed with the Gerardas dissection. This has been described by several authors in the past. It's defined as RAMS, as described by Strasberg. And essentially, it entails removing the anterior aspect of the Gerardas fascia and the Gerardas fat underneath the pancreas. You can see here that the vein is reflected, but we're resecting the fatty tissue underneath. It has shown to improve the rate of nodal dissection, decrease the positive margins, and also decrease the rate of recurrence or local regional recurrence in this area. You can see that sometimes, depending on the amount of fat of the patients, which in the US is not minimal. Sometimes we need to, in ischemic patients, we need to dissect the choroids and expose the anterior aspect of the kidney, as is shown here. Later on, we put the specimen in the bag. We often separate the tail of the pancreas from the spleen in order to morcellate the spleen, unless the tumor is really close to the spleen, in which case we want to remove the specimen completely intact. Let's review the perioperative outcomes of minimally invasive and robotic distal pancreatectomy. Of this topic, probably the most standard trial is the Leopard trial. This is a multi-center, patient-blinded, randomized controlled trial that included 108 patients, 14 centers, and was published a couple of years ago. This showed that a minimally invasive approach was associated with longer operative time, less blood loss, less TGE, improved quality of life, and a conversion rate of 8%. However, we should caution the audience that only 5 cases of these 108 patients were performed robotically. Therefore, we have to be cautious when we extrapolate these data to the robotic approach. Subsequent randomized trial, the single-center study, the LAPOP study, showed that confirmed a shorter length of stay and improved quality of life with the laparoscopic approach, but no robotic cases were included in this trial. So we're left with multiple reports that have described safety, feasibility, and improved outcomes of the minimally invasive approach, and there's over 10 systematic reviews and meta-analyses, the most recent ones including increasing numbers of robotic distal pancreatectomy. Of these meta-analysis and systematic reviews, I would like to highlight the one performed by Gabrielidis in 2018 that included 35 studies, 6,700 patients. Half of these were open, 40% were laparoscopic, and 11% of them were robotic. The conclusions of this trial included that the robotic distal pancreatectomy, when compared to the laparoscopic approach, showed less blood loss, shorter length of stay, and lower conversion rate. I would like to emphasize the particular benefit of having a lower conversion rate. This is something that we studied in our group a few years back. We looked at the National Surgical Quality Improvement Project database for 2 years, 2014 and 15, and we collected 2,900 cases. Much of them were open, but 1,100 were laparoscopic and 353 were robotic. The main conclusions of this study is that conversion was associated with a higher morbidity rate than completed minimally invasive or open approach. So converting from minimally invasive to open is a lot more morbid and usually associated with more complications. It is important to mention that in this data set, the laparoscopic group had a conversion rate of 17% versus 8% in the robotic group, so essentially double. Let's talk about oncologic outcomes. One of the reasons for the lack of the adoption of robotic distal pancreatectomy includes concern for the oncologic outcomes of this minimally invasive approach. Several single institution series have shown no difference between minimally invasive and open approach, and there are several systematic reviews and meta-analysis shows no difference in margins, recurrence, or survival, including this Cochrane review from 2016. Yet, there is lack of prospective randomized trials with the robotic approach alone. We hope that the ongoing diploma trial would increase the level of evidence available on this topic. The same group of investigators published a couple of years ago a pan-European propensity score match study, a diploma study. This includes 34 centers, 11 countries, 340 patients in each arm. And they found no difference in possible complications. You can see on the right, no difference also in overall survival. Yet the minimally invasive group had a higher rate of RCO resection with 67% versus 58%, lesser geroidofascial resection, lesser number of lymph nodes, and again, a similar median overall survival. It is important to mention that the resection rate, or the RCO resection rate, was only 67% in the laparoscopic group and 58% in the open group, which is particularly low considering previously published series. It is also important to caution the audience that only 16 cases on the minimally invasive arm were robotic. So the chance of being able to extrapolate this data to the robotic approach seemed dismal. So we're left with multiple series reported by different single institutions, including the one in Pittsburgh, Italy, Korea, etc. And I will just highlight the one report, a retrospective report from Raouf and collaborators, which look at the National Cancer Database. This includes 700 patients, 600 laparoscopic, and 99, almost 100 robotic. And as you can see in the curve on the right, there was no difference in overall survival. Yet there was some difference in conversion to open, as I described earlier. 27% of the patients in the laparoscopic group were converted to open versus 10% in the robotic approach. Positive margins were only 15% in the laparoscopic group and 16% in the robotic group, which is much more acceptable in the previously reported European series. And the length of stay seemed to be slightly better in the robotic group for 1 day, but this did not achieve statistical significance. In order to conclude regarding the perioperative outcomes, and mainly the oncologic outcomes and indications of minimally invasive approaches for pancreatic resections, I want to highlight the Miami International Evidence-Based Guidelines that were published a year ago. This is a result of a consensus meeting led by Horatio Ashburn from Florida, United States. And I'm lucky that I was able to participate and collaborate with this experienced group of pancreas surgeons that included 70 surgeons from 17 countries. And we were able to answer 28 evidence-based recommendations in a massive work and effort, again, led by Horatio Ashburn. I want to mention that regarding the discussion topic today, these guidelines concluded that a minimally invasive distal pancreatectomy for benign and low-grade malignant tumors is to be considered over open approach, since it's associated with shorter hospital stay, reduced blood loss, and equivalent complication rates. And this is a grade 1B recommendation. When it comes to minimally invasive distal pancreatectomy for pancreatic ductal adenocarcinoma, this appears to be a feasible, safe, and oncologically equivalent technique in experienced hands, although prospective comparative studies are lacking. This is a grade 2B recommendation. These recommendations have been endorsed for most of the HPV or hepatopancreatic societies across the globe. Regarding training and learning curve, I would like to highlight our previously reported data. This is a paper we published from my former institution, University of Pittsburgh. We reported 100 consecutive cases. This is the first 100 consecutive cases of robotic distal pancreatectomies. And we found through this Q-sum analysis that after 20 cases, there was a significant decrease of the operative time. And again, it plateaued, became even further lower operative time after 40 cases. Similarly, after 40 cases, there was a trend towards decrease clotting window 3-4 complications rate, as well as decreased rate of readmissions. There's also an interesting report regarding learning curve by Dr. Ugo Boggi and his team that also have similar results than ours. I cannot emphasize enough the need of training and deliberate training for robotic surgery. As we mentioned in the previous slide, the learning curve is steep, and one way to decrease the length of this learning curve is with adequate training. This was also summarized in our paper, and we have incorporated in our training program for fellows and residents much of the work performed by Dr. Melissa Hogue and Dr. Say when at the University of Pittsburgh. I think that I saw in the program a talk from Dr. Hogue, so I'm not going to dive deep on this arena, but I will just mention that we follow these 5 steps that include a lot of virtual reality simulation. We have a dedicated robot just for VR simulation training where the residents and trainees and fellows get familiar with the equipment and the console. Then we have several biotissue drills in which they are actually performing inanimate drills and dry lab operations in our sim center. Video library review to get familiar with the procedure. Surgical training happens in the operating room where we have coaching and mentoring directly by the faculty training or coaching these trainees. And we have an ongoing skill assessment. We record all our robotic pancreas surgeries and HPV surgeries for that matter, and often we score them and provide feedback to the performing trainees and surgeons. We also have an OR black box that allows us to collect data of what is happening in the operating room during these procedures. Just to highlight some of the particular benefits or advances that the robotic approach gives us, I want to present this case that we presented at the American College of Surgeons meeting a couple of years ago. This is a patient that underwent a distal pancreatectomy with celiac artery resection or DPCAR with portal vein resection and reconstruction for a locally advanced pancreatic adenocarcinoma. This is a 54-year-old male that had right upper quadrant pain, family history of bladder and breast cancer. You can see this pancreas neck and body mass extending and circumferentially involving or encasing the celiac trunk and the splenic and the hepatic artery. You can see it's also impinging the portal vein here. This patient underwent EGD EUS and biopsy EUS guided that confirmed the presence of a pancreatic adenocarcinoma. After 20 cycles of fluids and 5 fractions of SBRT, his CNNT9 dropped from 61 to 22, and we offered him surgery. For the interest of time, I'm not going to show the entire procedure, dissection. The previously described steps, gastrocolic and short gastric dissection, mobilization of the spleen, etc., have been performed at this point. I'm only going to show the vascular dissection. Here, by dissecting the common hepatic artery that in this case had anatomical variance coming underneath the portal vein. This is the pancreas body, and it is still attached to the portal vein. We're dividing the hepatic artery there, and now you can see again the invasion of this pancreas mass into the portal vein. We're dissecting the portal vein higher up towards the liver. We're also obtaining distal control towards the SMV, and again, this is the pancreas mass. Now we're lifting out the pancreas mass of the retroperitoneum, dissecting the anterior aspect of the aorta that is showing up here. Of note, we have separated and divided the spleen distally that facilitates the mobilization of this pancreas specimen. We're circumferentially dissecting here the celiac trunk or celiac artery. You can see the aorta, celiac trunk, and the takeoff of the SMA right here. After we circumferentially dissected this, we divided with a vascular linear stapler. And then we proceed to our portal vein resection with clamping proximal and distal. We use just robotic scissors to excise the specimen. We have mobilized the liver and the hilar plate for adequate reach, and then we proceed with our portal vein reconstruction. We just perform the same anastomosis that we perform otherwise open with a 4-0 purling suture and an RB1 needle. This is the completion of the anastomosis. Took roughly 15 minutes to complete, and we're removing the clamps in this view. You can see a little bit of a chyle there. This video I present just to show and highlight how much more dissection we can actually do with the robotic approach in comparison with the laparoscopic approach. I do believe that this is a reason why there's lesser conversion rate in patients with the robotic approach and laparoscopic approach, because it allows us to complete more complex cases that otherwise would not be feasible with laparoscopic technique. In conclusion, we could summarize saying that the robotic distal pancreatectomy is safe, feasible, and reproducible in qualified hands. This approach afforded advantages compared to laparoscopic and open approaches, with improved preoperative outcomes and non-inferior long-term oncologic outcomes. The widespread adoption remains limited due to a steep learning curve, limited access to a technology, and higher cost. And prospective randomized studies will be ideal and necessary to validate the long-term outcomes of this approach compared to open techniques. I want to thank you again, the Society, for the invitation, and I'll be willing to take any questions at this point.
Okay, so we are moving to Verona with the presentation of Roberto Salvia. I see you, Roberto. Are you online?
Oh, yeah?
Yeah.
Yeah, good afternoon. I'm
Siena,
here.
surgery.
I sent my video, so probably the presentation is pre-recorded.
Okay. We have seen this pancreatectomy without spleen preservation. You are going to present your experience of robotic surgery with spleen preservation. Please, Roberto, go on.
Ladies and gentlemen, good afternoon. My name is Ugo Boggi from the University of Verona. Unfortunately, yesterday we had a contact with our colleague that resulted positive for COVID-19, and so now I'm here in my presentation instead of being there in Pisa at the meeting with all of you. So I have to apologize, and now we can start with my presentation, and I'm sharing my screen with you. So the presentation is focusing on robotic spleen preservation as a pancreatectomy development experience. And well, the first question could be why we should preserve the spleen in distal pancreatectomy. Well, why? I don't know if I will be able to convince you about the possibility to perform a spleen preservation. I don't know how many evidence-based medicine we have for the importance of the spleen preservation. I have some thoughts that I am going to share with you. First of all, about the spleen. Of course, if you consider the weight of the spleen is around 150 kilograms, but we have a lot of blood in the spleen, and we can save blood. It's important for our patient, or at least could be important, of course, relationship of their situation, their comorbidity, but in some operation, if we lose lots of blood, probably safe blood, saving the spleen could help our patient. Then we have the problem of the post-splenectomy infection. Of course, after the vaccination, this is not a problem anymore. Still, if we have a sepsis, the patient with and without the spleen related to this bacterium, the mortality rate in the group of patients, the change of the mortality rate of the group of patients that are with the splenectomy is 5 times higher than in the group with the spleen. And that means that the spleen could play a role. Another role that the spleen could play is about the vascularization of the stomach. In fact, if you leave the spleen and the splenic and the venic spleen and the splenic artery, you also can leave the gastroepiploic vein and artery. And so you can leave a better vascularization of the stomach. And another fact that I like to show you, if you have the spleen and you remove the body tail of the gland, if you have a collection in this operation, and it can happen in 30% of the cases, the collection, instead of going to the splenic lodge, can stay in the pancreatic lodge, and you can drain your collection using the US instead of the operation or percutaneous way. That could be an advantage in some cases. Well, but first of all, the indication. Well, the indication for distal pancreatectomy with the spleen preservation are mainly the neuroendocrine tumor G1. So we are talking about patients in which we have a tumor more than 2 centimeters in diameter. Otherwise, we can follow up these patients. G1 without any sign of suspicion. We have 2 cases in this case in which we performed a distal pancreatectomy with spleen preservation. Another indication are for sure the cystic lesion of the pancreas. Here we have a cyst in the tail of the pancreas, and in the left first case here, in which we are able to perform a chimoral resection. That means that we are able to preserve the vein and the splenic artery. In the other two cases, as you can see, we perform a wash of resection, because in the first case, in the middle, because the cysts presented the thickness wall, so we prefer remove also the splenic vein and artery. And in the last case, because of the nature of this cystic lesion, was a pseudopapillary tumor, we decide to remove the spleen, the artery and the vein in this case. This is our experience. In the last 5 years, we performed 34 robotic spleen preserving distal pancreatectomy. In 72% of the cases, we perform a chemo, that means we respect the vein and the artery. In 10 cases, 28% of the cases, we cut the vein and the artery, and we leave the spleen thanks to the gastropoploric artery and vein. And so we were able to leave the spleen in this condition. Looking at our experience, as you can see here, no differences between two groups of patients, but I'd like to underline that the size of the tumor when we perform the wash was double than in the cases in which we performed the chimoral resection, and this difference is statistically significant, and the number of lymph nodes that we were able to remove in the case of Koshov were 3 times more than in the case of the chimoral resection. And also this data is present a statistical significance. Well, in terms of comparison in the post-operative course between the two techniques, chemo and Koshov, as you can see, there is any statistical significance between the two groups. Is very nice because, of course, is leave to the surgeon the possibility to choose the best technique that he prefer in case that he wants to preserve the spleen, of course. Of course, it's quite impossible to reach a conclusion because of the limitation of our study, because it's a retrospective study, of course, the small sample of size, and we don't have data about the long-term outcome. Beside our study, there is another study that I like to present. It is the Pisa experience, consisting in 54 pancreatic distal resection, pancreatic distal resection with spleen preservation robotic. In this case, the author performed in 96% of the cases the chimera. That means that they leave the vessels in almost all the cases. And another fact to be underlined is that in 13% of the cases, these operations were performed in presence of a malignant tumor at the final histology. This is a study, a multi-center study that involved 29 European institutions with the conduction of minimally invasive distal pancreatectomy with or without preservation of the spleen vessels. And this multi-center study was able to collect 1,000 patients with intended minimally invasive spleen preserving distal pancreatectomy. And among this group, in almost 80% of the cases, the operation was performed with spleen preservation, but in 20% of the cases, of course, there was a failure of the preservation of the spleen. In the vast majority of the cases, also this experience, the operation was chimera, but in considerable number of patients, also the abortion was performed. Well, because of the main aim was the clinically relevant splenic ischemia, and the major complication means having been more than 3. As you can see here, in the two groups, there is any statistical significance. That means that also in this multi-center study, there's no difference in secondary splenectomy and other short-term outcome between Kimura and Orshoff technique. But that's quite interesting to be underlined. If you consider the patient with spleen preservation, that means, of course, 800 patients, and the others, so that means the patient in which was performed the splenectomy was unplanned. Well, there are many statistical significance differences among this group in terms of operative time, blood loss, conversion to open procedure, emergency conversion, and pancreatic fistula and readmission and mortality. And all these differences are statistically significant and are in favor of the spleen preservation, not because of the spleen, the splenectomy, sorry, but because of the splenectomy was unplanned. So that means that there was bleeding inside of the operation, so that was the need of conversion to make the splenectomy, and probably this is the problem. So the conclusion of this, I think that we can make some consideration with this result in terms of course, Kimura first, otherwise Orshoff, otherwise do the splenectomy. But when you want to decide to do the splenectomy, please consider the splenectomy before the bleeding, before the emergency will be over, because the outcome of this patient is better otherwise. The outcome of the patient of the unplanned splenectomy is worse because of course, the blood loss, mainly the blood loss. So another paper published from our group, but this is a multi-center study. The multi-center retrospective study always focuses on the minimally invasive and open Orshoff and Kimura technique. And just to underline that in the minimally invasive group of patients, the outcome, the post-operative outcome was better than the open technique. And another fact is about the sequelae, because in this group of patients we were able to reduce the long-term sequelae. And also in terms of sequelae, we have a better situation in the group submitted to this operation in a minimally invasive way than compared in the open surgery. This is another multi-center study, but I don't want to talk about this study that is out of my duty because our body was laparoscopic distal pancreatectomy, but just to say that when we perform distal pancreatectomy robotic surgery, of course the operation is longer, but we have a lower resection rate and higher spleen preservation rate. So if you want to preserve your spleen, and the rate is in favor of the robotic surgery instead of laparoscopic surgery. So in this case, so it's better if you choose the robot. And here I have an experience. I like to show a couple of video about some tricks for that. This is our way to handle the stomach before the operation. After that, when we open the lesser sac, and when we use this technique using this simple drains, these are the easy flow, and we put one of these, or maybe sometimes two, and we bring this through the abdominal walls. In this case, we can have the access of the pancreas here. As you can see here, we have the gastric vein, and here we have the spine artery, and we can with all the robotic instruments. And in our case, we have 2 consoles, and we use 3 instruments. And in the second console, the surgeon can use the other instrument, and so can train himself to this type of operation. And this is the mobilization of the gland. We use here the inferior margin of the gland using the hook, but more recently we use the cesium, but we prefer to mobilize all the gland, and then we can flip the pancreas, and then we recognize the vein from the posterior face of the pancreas. In this case was particular because always from the posterior side we were able to recognize also the artery, and here we recognize, we put a loop in the artery, and then another loop in the vein, and then after that we put the loop, then we start to recognize and to divide the vein, the vessels from the parenchyma, and this is the way that we follow. Generally, we prefer start with the vein and then the artery in this case, and we go from the neck of the pancreas in the direction of the tail. And here our way to cut the pancreas, we can use both. In the left side, we use the reinforced stapler, and in the right side, we use ultrasound or radio frequency. In this case, we use, you can see here, and in general, we are very slow, so it takes 3 minutes because we don't want to crash the pancreatic parenchyma, and so it takes time. We will be stable, but also we will be with a seizure, like in this case. And this is the result after this picture has been taken in last operation that was open, in which we performed a total pancreatectomy because of the pancreatic area was really soft. The patient was already diabetic and insulin dependent, so we decided to remove the pancreas, but we decided also the total pancreatectomy. We say, well, it's nice to remove all the vessels because of the vascularization of the stomach. This is the reason why I told you in my previous slide, and so we prefer to leave the vessels and the spleen. The conclusion of my talk, well, of course, with the robot, the spleen percentage of pancreatectomy is feasible and a valid option. The treatment of course, benign a tumor with a certain biological behavior. So the selection, the good selection of the patients is crucial. And the meaning of this approach was associated with the less long-term sequelae as compared to the opening, spleen pancreatectomy. There are no data about possible differences between the Kimura versus Roche in the long-term outcomes. Open question, of course, probably we already talk about that, you already talk about that, about the cost, the availability of the UR for the robot, and the learning curve, because the learning curve is a huge problem, because we have to teach to our residents also the robotic surgery, and it's really difficult availability of the robot with this cost. And if you don't have the double console. These are the articles that I used to prepare this presentation. Now just to say thanks, thank the colleague for the Pancreas Institute, and this is the group of of surgery that are involved in robotic surgery. Alessandro Esposito is here beside me. Is the coordinator of the robotic project in our department. So thank you very much for your attention, and I'm here probably not in person but live if you have answer for the discussion. So thank you very much.
Do we have 5 minutes, 10 minutes for discussion? If there are any questions from the floor? Or Professor Salvia? No? No one? I have a question for Professor Boggi. Just to... He is not a presenter, but it's very interesting during the presentation of the meta-analysis. The presenter showed that you have an incidence of 46% of DGE following pancreatic autodenectomy. Is it the same incidence as in open surgery? I agree with the 46% because it's the same incident I recorded in my data.
The issue of DGE in minimally invasive pancreatic adrenectomy is really an issue because you would expect clearly less DGE. But there are some issues that had to be, I would say, refined in the technique, and the work is still ongoing. Someone, for example, some groups decided to preserve the stomach, but then they do a posterior gastrojejunectomy. That means that the stomach was not preserved. You know, it's like a gastrojejunal bypass. So there were many tips and tricks to learn. For our experience, it is decreasing. It is not that much higher, but you need to learn on small issues, like we did in open surgery. It's exactly the same. So those results are those referring to people who have started, and I have also to consider a stupid thing, that the duodeno or gastrojejunectomy comes at the end of a very long procedure. It's probably the most, the anastomosis, because you also perceive that it's not very difficult to do. Maybe it's the one that poses, several technical bias. But this is still an ongoing issue, the DGE. It needs to be refined, but it's not anymore that high. I had a question for Roberto. Roberto, if you could freely decide using the robot whenever you wish, or laparoscopy whenever you wish, do you have any selection criteria to decide for the distal pancreatectomy in which you on theoretical grounds could spare the spleen to decide between robot and lap? Or you would go always for robot or always for lap? So what is your opinion?
Well, can you hear me? I have an echo. Can you hear me? Well, the answer is thank you, Ugo. And if I have the availability, I always choose the robot. If I don't have to think about the cost and nothing else, I would really use the robot. As in the previous presentation, when the professor of story of medicine during his talk, he said, well, probably in the future we will say, oh, well, look at the instrument that they were using 20 years ago. And I think the same as probably in the future they will judge us about our robot, but we have to use it. And I think that the future is in this way. And so if it's possible, regardless the availability, regardless the cost, I will use the robot every time I can.
It's not completely related to pancreas surgery, but who is so brave to make a strong comment on meta-analysis? Who would like to make a consideration on meta-analysis? Because the majority of our scientific conclusions are on meta-analysis. But there are many, many drawbacks on considering this data. Who would like to say one comment, one? No one? Alessandro?
Not on meta-analysis. I want to maybe to end the section on pancreatic surgery by asking me to the floor if the majority agree that at the present now probably for pancreatic duodenectomy the best way is a robotic approach. And for distal pancreatectomy, the best way is a laparoscopic approach in this moment.
We're not totally agree with you. So I see your point, and indeed for the moment, we do all our minimal invasive WIPO robotic, and I would say 95% of distal laparoscopic. And this is simply because I cannot use the robot for the distal. Because otherwise, I would agree with Roberto. I see that it's difficult, really difficult to show a difference between two techniques of a minimal invasive surgery. If you are successful in doing a laparoscopic distal, so you are simply successful, and the difference becomes very small with a different approach. And we know that you are facilitating in reaching that result with the robot. The conversion rate is lower. The issue for which I'm not using systematically a robot is that because I'm not allowed to do. This is the issue with the robot, is accessibility. And in other words, if you could assess the robot on an everyday, would you use it for your distal? The issue is that you probably, I don't know what it is at all hospital, you have limitations, and this is why you struggle to use laparoscopy. And then you achieve good results. That's fine. But we are not really in the condition to say what I prefer to do, because you do simply what you can.
Yes, in this moment, probably is the simple way to act for us, because it's not so realistic to use robot for every procedure in this moment. Maybe next years it will be different. I mean now at this moment.
Yeah, but I agree. So I agree. If you ask your question like this, I agree. So I make a selection. I make a selection of my cases, and I believe that the robot is more rewarding for a WIPO. And so I basically use on every week my robot for a WIPO. But if you ask me about an ideal world, so we are talking about technology, we are not considering the extra relevant issues, the extra relevant issue of money, cost, hospital, and so and so. And I have to choose about the technology. I say I prefer to do a distal robotically. The robot is simply a laparoscopy boosted. It's a little bit better than laparoscopy. You cannot debate about this. The issue is whether or not I need the extra value. And for sure, you don't need for a cholecystectomy. Okay, you don't need this extra value for an extra simple procedure. But when you go to a distal pancreatectomy, which, is not a WIPO, but it's a complex procedure, why not use that value if you can? And the issue is all about cost and availability. If we do have the robot on an everyday, you probably will use it, Alessandro. The way you're struggling not to use it, I understand. It's the same we do. But it's not a free decision.
Okay. Okay. So we can finish this session. Very, very, very interesting. Thanks again to Ugo and to the organizer. And we leave the podium for the esophageal surgery. Thank you.
Thank you very much. Bye.
Ciao Roberto.
Bye bye.
Non abbiamo salutato, va bene. Ah, ecco qua.
So this section should be chaired by Franca Melfi, who is a thoracic surgeon from Pisa, but she has some issues at the hospital. She cannot be here. And Giovanni De Manzoni, who should be online. I verified before that he was there. I don't know if
Good afternoon.
Giovanni, hi, how are you?
Fine, thank you, thank you. Sorry not to be there.
Thank you for making it. So I leave it the session to you.
Thank you very much. So good afternoon to everybody, and especially also to Ugo that organized this Congress on a very hot topic. You know, all the day you were discussing about robotic and how robotic could be useful in general surgery. And I think that this chapter of this session 5 is very important, because believe me, I changed my mind because I realized, for example, that the esophageal surgery using the robot is really in the thoracic approach is something from the oncological point of view changed the life. Is really a very good oncological operation. So and with the robot probably we can overcome the problem with the esophagogastrostomy that in this 10 or 15 years make problems to the esophageal surgeon with leakage, with the increasing of the leakage rate. I believe that with the robotic approach, we can overcome this problem. And in my center, we already have done 36 cases of this Ivor Lewis with robotic approach. And I have to say that the morbid mortality is the same of the open approach, with the oncological results, number of lymph nodes, clearness of your oncological fields absolutely superior. So I'm really interested today to know what's the experience all over the world, because we have speakers from Utrecht. Van Iglersberg is very famous in Europe for the robotic program in the upper GI surgery. Melissa Hogg from the USA, and also Stephen Ockwell from Buffalo. And we have a very important experience also from Italy, because it's the experience of the Grosseto group that will be presented not by Dr. Coratti, but anyway by Dr. Francesco Guerra, that is an assistant of Dr. Coratti. Anyway, you know that in Grosseto they first started with this experience, so it will be interesting to know how is the situation after 10 years, I think, of experience. So I would like to start, because we have nobody in presence, just I think the Dr.
Hello, this is Melissa Hogue, and today I'm going to be talking about robotic gastrointestinal surgery. So
we can start with I think Melissa Hogg, that is a recorded speech. Please, you can start from the...
Hello, this is Melissa Hogue, and today I'm going to be talking about robotic gastrointestinal surgery, the learning curve, educations, and outcomes. I do have disclosures from Intuitive Surgical for training and coursework. Now, the goals of the lecture today are going to be to state some of the learning curves from different GI procedures. Now, I'm a pancreatic surgeon, so there may be a little bit more pancreas, but we're going to go through some other programs as well. We're going to talk about some education programs that I found out there, but maybe about my education program in robotic pancreas in a little bit more detail. And for outcomes, you know, this is a 2-day course. There's going to be a lot of outcomes in most of the other ones. So for the outcomes I'm going to focus on here are really outcomes related to teaching, education programs, and learning curves. So really, you know, what is so critical about this topic today with robotic GI training is that industry has really outpaced the education. And even though robotic surgery has been around a couple of decades and utilized extensively for gynecology and urologic surgery, really for general surgery, including GI, HPB, things have been relatively recent within the last decade. And you could see by this blue line here that things have really just skyrocketed in in terms of robotic case volume. And this is skyrocketed without a parallel inclusion of different education programs. So at UPMC, we looked at our learning curve for the robotic Whipple. And you can see here about 3 phases where we thought of the setup and the platform as being one phase, just the surgery and just kind of getting down and dirty with the procedure itself as being the second phase, and the last as being optimization, where you're really just honing your skills. And what we found were that conversion and EBL had about a 20 case load, and that's really about how to control bleeding and get yourself out of bleeding. I think both of those numbers reflect that. The second set of learning curve was pancreatic fistula and lymph node harvest at about 40 cases. And I think this is really getting your tying down, especially with small little suturing, as well as being able to dissect directly on blood vessels. And the last and hardest thing to get down is OR time. Now, this is by no means the only publication out there in regards to the robotic Whipple learning curve. There's several other ones that you can see here that are depicted between Shear showing that console time and blood loss with 20 cases, as well as Chen, where operative time and blood loss is 40 cases. So this kind of has the gamut of about 15 to 80 cases in terms of EBL. And I think when you're looking at learning curves, it's really important to see what the total N is of the series, because if something has a low learning curve, you also may want to see if the case number is very low as well. Now, moving along to the robotic distal learning curve, again, this is the same kind of QSUM learning curve here, showing the setup, the platform, and just surgical optimization in 3 different phases. And here we just had a OR time and readmissions at about 40 cases where things were optimized. And there were about 100 cases in this series. And again, looking at other different series out there, you see a gamut of 5 cases to 40 cases that were seen in our series. But again, this Takahashi, I think, had about 12 total cases in this series where they determined the learning curve to be 5. Now, this is an older review I did about 3 or 4 years ago, looking at different learning curves. And really, you could see a different variety of learning curve here, where like Whipples were 10 to 40, Whipples 33 to 80, like I depicted. Also with gastrectomy, there were some like 18 to 20, rectal 21 to 55. And at this time, I think there was only one hepatectomy learning curve, and that was around 15. But we're going to go through some of the more updated data for other GI cases here now. And this is a case or a report from Song et al. Looking at the role of robotic gastrectomy compared with lap gastrectomy. And they looked at 60 cases total, and they had broken these down into early lap, recent lap, and early robotic. And what they found were that there were a lot of similarities between the early robotic and the later lap series. And they showed that there was a decrease in blood loss, increase in lymph node harvest, a decrease in length of stay, and earlier diet initiation in the robotic group. And that's the early first 20 cases of robotics compared to some of the last 20 cases they had done in laparoscopic. So they somewhat hypothesized that people with lap experience could have an easier time learning robotic surgery. And that sort of hypothesis has come through with a few other publications, not only on the gastrectomy learning curve, but even in some of the subsequent other robotic GI learning curves. And then one study showed that there may be a caseload of for a robotic gastrectomy of 11 to 25 cases if people had previous laparoscopic experience, but that may be greater, more 20-25 cases if people did not have laparoscopic experience. And then there is one study by Kim et al. And again, this is where it's really critical to see the number of the cases in the learning curve, where this was a really huge series, over almost 700 patients, and 172 of them were robotic. And in this, they showed that 90 was the learning curve. And again, even when you see that the learning curve is somewhat half of the series, it also calls into question whether they have actually reached a learning curve yet. But I do want to point out this paper here from the Shizuoka Cancer Center in Japan. And I think that one of the key things is the majority of the data regarding learning curves in minimally invasive gastric surgery comes from Asia. In addition to having such a robust experience in robotics and laparoscopy, this center also has a training program. And this has sort of a 3-step training program here, where you could see in the earlier steps that these are courses led by Intuitive and just kind of performing a certain amount of hours on the actual system to just learn basics. And this is kind of the 8-hour course, in the US that sort of required as a baseline for most credentialing things. But then the second step here is that, under the guidance of a proctor, they're supposed to perform over 10 gastrectomies. So having 10 cases proctored is a lot and would be great, for anyone to have that experience. And actually with this, essentially that first case is almost all done by the proctor, and then things are relinquished over time. And then the last step is kind of receiving a rating of B or higher from the proctor and all the items in their evaluation. And I think this is awesome, but also very difficult because, how do you come up with a grading system? Who determines the grading system? And who's capable to analyze the grading system? And these are all questions that come up. But I commend this program for setting forward this protocol. So with the robot learning curve, that there has been a systemic review. It has only about 6 robotic studies, and they show the learning curves between about 15 and 30 cases. Within the systemic review, they also have 28 lap cases with a variation of 5 to 310 cases per their learning curves. For rectal, I think, by and large, the learning curve has been shown to be longer than for colon. The key for the colon is more intracorporeal anastomoses, which we'll find later too, that are, anastomoses are pretty easy to replicate in a technical training setting. But here's a multi-phase learning curve study from Singh et al. Showing about 3 phases, and this includes a learning curve of over 100 cases, where really the initial cases are basic robotic skills, and that may be about 35. And then phase 2, they actually had an increase in the OR time. And they sort of attributed this to doing more challenging cases than they did in their initial experience. And then this was kind of a second hump learning curve that can be, around 93 cases. And the last part, of the learning curve was pretty flat. And this is just the finesse as you just gain little tips and tricks over time. And now there have been a few other studies here too. And, some have shown, 25 to 40 for their learning curve. And another study looking particularly at difficult cases showed that this may be higher at 75. Now, I was involved in a German program earlier this year, and I saw Dr. Amjad Chima give this great talk on rectal robotic training, so I'm not going to replicate that here. But he's from England, and they have developed a pretty substantial training course, including simulation, system tools learning, index procedure learning, animal cadaver courses, case observation, hands-on proctorship, and formative assessment. And really this is sort of the gold standard if we're able to do it. Now, liver has really less, it's kind of like more recently to the game, and not as many different things out there in terms of training as well as learning curves. But there are about 4, key papers you can find, looking at different things. The first one used conversion. They saw that to be about 30 cases. The second study was based on a difficulty index, and this was several hundred cases, and they found 16 to be the learning curve. This study by Chen et al. Had 2 learning curves. EBL was about 40 cases. 15 was OR time and length of stay, which is interesting because that's sort of opposite what we found in our Whipple learning curve, that the OR time was longer. And the most recent one was by Magistri et al., and they found about 30 cases. And this included OR time, EBL, and complications to be improved after that time period. And now I'd like to segue a bit to, how do we improve and teach technical skills? Are there ways to minimize the learning curve and maximize the emphasis on maintaining and improving outcomes? And for this, we have to look at the components of the learning curve. Surgery just has multiple components. You need to master the instruments, which is, for me, is a simulation curriculum. You need to master the handling of tissues, which for robotics has no haptic feedback. You have to master the procedures. For robotics is fixed in one quadrant. You have to master the psychomotor performance. And for robotics, you'll use, your hands, your feet, you're swapping from side to side. And always with everything with surgery, there's good decision-making and judgment. So the components of robotic training that I have sort of used have been a simulation curriculum to master the console, an inanimate curriculum to master the loss of haptic feedback. You have to master the procedures with a video library, the psychomotor performance with a sort of surgical curriculum, as well as the decision-making and judgment. And here you can see somewhat of a rationale that in simulation, you can sort of use, your right hand, your left hand, and you're left on your own to do this of your own device on your own time. And the nice thing about this is that, it has a scoring system, and it allows you to kind of really learn how to use the robotic platform. And that's in contrast here to the inanimate environment, where you can use the same needle control drills to use your left hand, backhand, left hand, forehand, right hand, backhand, etc. But really this, is sort of, antiquated, and it doesn't have a lot of excitement for surgeons. But if you move on to sort of deliberate practice drills like you see down in the bottom left corner, where you're sewing a pancreatic jejunectomy, and you can really make these biotissue drills that are deliberate practice for, sort of any kind of simulated parts of the performance. And, this sort of allows you to learn how to do this and whatnot before you're actually in the operating room. The first time you sew the human pancreas does not have to be the first time you've practiced suturing. Second generation being the next group of surgeons, and the third being the fellows. And we looked at time, conversion, EBL, lymph node harvest, and each of those improved with subsequent generations. And generation one, as I mentioned, was the first generation of Dr. Zay, Dr. Zerkat. The second generation was Dr. Zerkat and myself that had subsequently learned. And then the last generation were our fellows. And you could see that there was sort of no reinventing the wheel, with each multiple generation. And specifically, you saw that the new set point that each generation started at was way beyond the learning curve. And the second generation had mentorship, and the third generation had that curriculum that I just discussed in addition to mentorship. And then I also did a similar study in distal pancreatectomy. And again, the same three generations of Herb J. Jim Moser, Amr Zerkat, and myself, as well as then the fellows. And again, we looked at the difference in fistula and complications, and there is no change in that. And that's not super surprising, just because in distal pancreatectomy, there's not as many, complications as you see in the Whipple. But we did see an improvement in time, EBL, and lymph nodes with each step. So in summary, I'd like to say hello from Chicago, and just to say surgery in general has a learning curve, and this concept is revisited with each technique, whether it be open and then laparoscopic and then robotics. None of them are exempt from having a learning curve, but we must remember these things are multifactorial in that some things translate. Having the open experience in one organ may give you more, a better learning curve in subsequent laparoscopic robotic. Having some lap experience may improve your learning curve in robotic, and then doing multiple procedures, whether you do colorectal as well as liver, etc., that these skills could translate over. But I think one important take-home message is that training can mitigate these learning curves, and this should be an important component to building robotic programs. Thank you.
Thank you very much. It's pre-registered, so we can't do any question to Melissa. Anyway, it was very interesting to see how the system works and with the to diminish the impact of learning curve that it's present not only for robotic but for laparoscopy, but for open surgery, for everything. So I believe that this communication, it's very important to understand how it's possible to spread with our resident the robotic surgery. So I think we can move to the second presentation is from Richard van Ilexberger. I don't know if Richard is connected or is just giving us a registered presentation. Anyway, his experience. No, Richard is with us.
Yes.
Good. No, Richard. I'm going to present you. You are a very important person for the robotic program in Europe, absolutely. And also my fellows come to Utrecht and to see you. And for us, it's very important to have your experience that you are the first one to start with a real good program in RAMI, in robotic assisted minimally invasive esophagectomy. So please, Richard, it's
Thank you.
your turn. Thank you.
Thank you very much for the opportunity to present here an overview of the value of the robotic assistance in the abdominal phase of the esophagectomy. These are my disclosures. Now, most experience is coming from the robotic thoracoscopic part of the operation, as this is generally considered the most complex part where robotic surgery would aid the most. And so this is also typically the way we operated from 2003 on with a laparoscopic conventional abdominal approach. And this is also the technique that we used in our randomized controlled trial, comparing the robotic thoracolaparoscopic approach with the open transthoracic esophagectomy. And we found from this trial that the robotic assisted minimally invasive esophagectomy compared to open improves post-operative outcome in all aspects, with a lower percentage of post-operative complications, a lower percentage of cardiopulmonary complications, less pain at all points post-operatively, a better quality of life, a better short-term functional recovery at equal cost, and also oncologically comparable. That is why we consider the thoracoscopic robotic phase as our standard of care. What about the robotic abdominal phase? We have already, in the beginning of our experience, tried to do the abdominal phase robotically, but found it very difficult, mainly because of collision of the bulky arms of the standard system and the SI system. But that had completely changed with the introduction of the Da Vinci Xi. This machine is especially designed for multi-quadrant surgery, and with the small, elegant arms, it's very well feasible to perform abdominal gastric esophagectomy. The question is, what is the current implementation of the abdominal robotic esophagectomy worldwide? To find an answer, we have looked into the UGIRA web-based registry. The APGI International Robotic Association was established in 2017, especially to look into the worldwide implementation of the technique and also to stimulate interaction, proctoring, and establish guidelines. Here you see an overview of the centers that are currently active in registering their robotic esophagectomy data and also gastrectomy data in the UGIRA database, as you can see from Europe mainly, but also from the United States, South America, and Asia. And we recently analyzed these data to have a benchmark of the worldwide techniques on robotic esophagectomy and gastrectomy. And as you can see here in this data that was collected from 2016 to 2019, that if you look to the Ivor Lewis intrathoracic anastomosis versus Ewan cervical anastomosis, that the thoraco-abdominal phase is performed in Ivor-Lewis in about 53%, whereas the minority in the McEwen, 24%, use a complete thoraco-abdominal robotic approach. So that indicates that this technique is still in the implementation phase in those centers that use the robot for isophagectomy. This is the typical port positioning for the abdominal phase with a subumbilical assistant port and on both sides 2 robotic
Here we use the hook to dissect along the planes, and we use the cardiac as a retractor, as well as the vessel sealer that can be used as a retractor or as a coagulator. This patient also had a hiatal hernia. As you can see, we move along the left cross here and along the right cross to start the procedure. Then we go to the greater curve, and in this case, the fellow did the operation, and as you can see, using the dual console facility, we can use the cursor to point the direction of the dissection. Here the greater curve is dissected, using first the hook to open it, and then to use the vessel sealer to coagulate the structures, moving towards the spleen and the short gastrics, which can also be very nicely coagulated. The short gastrics are coagulated off the fundus of the stomach, sparing, of course, the gastroepiploic artery. Then the stomach is lifted up. You can use either the cardiac or the vessel sealer to lift, and the other instruments can be used to dissect the celiac trunk lymph nodes. This is the left gastric artery and vein that are dissected to start with opening the peritoneum. The vein can be coagulated. The artery is further dissected. And we clip with the wristed Imoloc clips. Here we use the vessel sealer also as a scissors to dissect the left gastric artery. Then we will create the gastric tube. We always use a centimeter to have 3 to 4 centimeter width of the gastric tube. And here we use ICG to look for the vascularization to find the optimal point of dissection. We use the Shortform 60 robotic endostapler, which is excellent in very precisely
performing the vertical stappled line. Exactly at the position that you like to have it without any twist in the right direction. I think this is the big advantage of this technique with the forearms, where the surgeon is completely in control. With the tube dissected, we can lift the lesser curve, and we have now more space to do the hepatic artery station 8 lymphatic dissection. And these lymph nodes are typically dissected separately and collected. Then we suture the tip of the gastric conduit to the lesser curve in order to align it in the right position for transhiatal retraction towards the thorax in a later phase. We conclude the abdominal phase with the creation of a jejunal tube that is positioned with the Seldinger technique. Here is the needle positioned in order to be able to position the P-lock barbed suture to make a purse string. And you can see how very useful the wristed instrument in this case are, because you are operating very close to the target, but using the wrist, purse string can be created very nicely. In this case, we used the Cardiere, and we changed the position of the instrument with the Cardiere in port number 1, the camera in port number 2, and the needle driver in port number 3, and port number 4 is not used, as you can see it standing there without any instrument. Here it is completed, and this ends the abdominal phase. What are the main advantages of the robotic abdominal approach? In my mind, it's especially a lymphadenectomy. I have performed many laparoscopic cases, but I really think that the lymphadenectomy along the celiac trunk can be performed more precisely with a higher level of detail, especially along the portal vein in station 8, but also station 9 and 11 compared to the abdominal laparoscopic approach. If you look into the literature on this topic, several studies have compared the robotic versus laparoscopic approach and looked into the lymph node yields. As you can see, there was no statistically significant difference, but there was a trend into more lymph nodes retrieved with the robotic approach. What is also helpful in our experience are the robotic stapling devices that are smart. They measure the pressure on the tissue and they adapt and compress accordingly, and can be really positioned in the right way, exactly as the surgeon controls them from the console. Also, the articulation is very helpful. What is also very helpful is the positioning and the construction of the purse string and the jejunal tube, which is really very convenient with the wristed instruments. Now, does the robotic abdominal phase translate into better postoperative outcomes? There is no evidence showing that. This is a comparative study by Park, showing in 98 patients no difference in postoperative complications of robotic versus conventional laparoscopic approach. And here is the duration of the procedure in 3 studies, and you see that in all studies the robotic procedure was significantly longer in the abdominal phase. And this is one of the first learning curve studies. They looked in two ways to the learning curve. They compared the first 26 to the last 46 patients, and they showed that indeed the docking time and also the console time was less in the last 46 patients. And they also looked into the Q-sum analysis and found that for console time, the plateau was reached at 14 cases and docking time at 16 cases, with an improved performance in the following cases, indicating that the learning curve was still going on in this cohort. Then what about training and proctoring of the RAMI procedure? Should we start with the abdominal phase or the thoracic phase? Up until recently, we always started with the thoracic phase, with, depending on the surgeon's experience, open abdomen or laparoscopic abdomen. But recently, we also introduced the start of the abdominal robotic phase. And we found that indeed the abdominal robotic phase has less danger zones compared to the thorax, but the exposure in the abdomen with the multi-quadrant surgery is indeed very challenging for most starting surgeons. And also collision is more common compared to the thorax with the forward arm technique. So the thoracic phase is much more standardized. Exposure is less difficult, but of course you have all the structures in the thorax that are very narrow and very difficult to avoid damage. So it really depends in our mind on the type of surgeon, the general or thoracic surgeon, the experience, open versus thoracolaparoscopic, which approach is preferred as a starting point in the robotic surgery. So in conclusion, the current evidence for robotic abdominal RAMI is scarce. Personally, I think that you can perform a very precise lymphadenectomy, especially along the portal vein station 8 and 9 and station 11. And this might translate in a better lymphadenectomy with a higher lymph node yield, but no evidence so far. Also, I think that the surgeon is very independent, performing the surgery with 4 arms from the console. Can do a very precise dissection, as stated, lymphadenectomy, but also the stapling is very, very precise. And I really like the geniostomy that can be done with the wristed instruments. So I think that in conclusion, we need more data. More centers should be collecting the data in the UGERA database, and I hope that all centers that are listening will join this effort. So thank you very much for your attention.
Thank you very much, Richard. Richard is connected, so if there is any question from the floor. Richard, I have to say that I do not perform the abdominal phase because of the long time. Because if I perform abdominal and thoracic, my operating theater is busy all day. Is it the same for you or not?
This is the same for us. I think that you should count about 6 hours for the complete procedure. I think, well, there is of course a learning curve involved, especially for surgeons that are very used to laparoscopic approach, and this is of course something that is challenging. But in the end, I had the same. I had experience of 15 years laparoscopic, and now do all cases robotically. I think as I told in the robotic. And the advantage is the preciseness of your dissection, the wristed instruments, and also it spares cost because the calculation that you use in the thorax is the same as in the abdomen. So the instruments can be used during the whole procedure, which also reduces the cost of the procedure.
Thank you very much. So have a good weekend and thank you for your big experience. Ciao.
Thank you so much. Giovanni,
bye.
Bye. Bye.
Thank you. So Now we can move to the presentation from Italy. I think that Dr. Guerra is on site in Pisa. Is very close from Grosseto. So if Dr. Guerra can start with advantage of robotic surgery in the treatment of multi-compartmental. Robotic esophagectomy results from a tertiary cancer care Italian center. Please.
Good evening and good afternoon to everybody, and many thanks for the opportunity to be here and presenting our experience with robotic esophagectomy, which relates to our experience from a tertiary care center, which refers to our previous institution, which is Careggi University Hospital in Florence. And it refers to the period 2014-19 and includes only oncological patients, 76 oncological patients, including the 45 Lewis procedure and 25 McCune and 6 patients who received transhiatal esophagectomy. So briefly, these are baseline patients' characteristics divided by the 3 series. And basically, a 3-stage was performed for cancer of the upper and middle third of the esophagus, while a 2-stage esophagectomy, according to Lewis, was done for tumors of the lower third and severe tumor type 1 and 2, while transhiatal esophageal resection was performed according to each patient characteristics and mainly for selected cases with relative contraindication to tolerate procedures in the chest. So surgical details were already described previously in previous reports, but let's look to our experience. So starting from intestinal dissection. We usually put our patients in a semi-prone position with a left side tilt of about 45 degrees. And this is our trocar positioning strategy. Basically, we adopt a fully robotic technique for the chest with 4 ports and 4 robotic arms. Why the semi-prone position? In our experience, there's a faster positioning of patients and more space to put our 4 robotic ports and the possibility generally to avoid single lung ventilation. Lastly, faster conversion where needed. We use normally an exercise system which comes from the left side of the patient. Briefly, the procedure is divided into 3 main steps. Step 1, opening the posterior space between the esophagus and the pericardium and dissect up to the arch of the azygos vein in a counterclockwise direction, and then the dissection moves down along the descending aorta with the transection of the mesoesophagus, which is normally encircled with the tape to improve traction, and then left side mediastinal dissection and closure of the thoracic duct. There are 2 examples. On the left, there's one of our first cases. We were using the hook at the initial experience. On the right, there's a case, a more recent case, where we use normally the monopolar scissor and the Western sealer. This is the dissection of the mesoesophagus, moving down toward the hiatus. Step 2, identification and isolation of the azygos vein, the arch of the azygos vein, which is divided normally with a vascular endostapler, and the division of the right bronchial artery, and lymph node dissection, which is moved to the carina. Here. To move to the third step, which is the upper dissection where needed, right and left paratracheal lymph node dissection, and where needed the dissection of the upper esophagus, which is illustrated here in these two cases. The use of monopolar energy should be very judicious to avoid damage and thermal injuries to airway system. Okay, to move to the abdominal phase, which is been already discussed, but briefly, we put the patient on a supine position with the legs apart with an anti-Vandenberg tilt of average 10 degrees. The robot comes from the right side of patient. Also in the abdomen, a fully robotic technique with 4 ports and 4 robotic arms. Robots in the abdominal phase to improve lymphadenectomy, to improve the control of possible bleeding, and to improve the handling of obese cases, and eventually to fashioning the jejunostomy as seen before, and improve surgeon economics. Abdominal step, very briefly, they have been already discussed. Full gastrolysis and cochlearization of the duodenal block. Formal lymphadenectomy, which is initiated on the upper margin of the pancreas, station 8, 9, and 11, proximal 11. The dissection of left gastric pedicle. Okay. Doesn't work.
It doesn't work, so we can jump the Dr. Guerra.
Yes, I'm trying to open again the presentation. Okay. Okay. So the mobilization of the esophagogastric junction and the hiatal dissection, and then the fashioning of the gastric conduit with local microcirculation assessment with ICG fluorescence. We used to do a pyloroplasty with the injection of botulinum toxin. And lastly, the feeding jejunostomy. So perioperative details, good hospital stay, good length of hospital stay, on average 10 days with excellent results about conversion, which was 0 for all series, and anastomotic leak, which was according to the ECCG of 13% on average. Cardiopulmonary complication, 14%, with quite significant 28% with regards to the McKeon series, and a 90-day mortality of 8% in total. Just a detail about our technique of intrathoracic anastomosis in the case of Lewis esophagectomy. In our early experience, we used to perform an unsewn anastomosis, which was currently changed to a complete stapled anastomosis. And then manual closure of the gastrostomy. So this is a little analysis of our result about our Lewis procedures with a comparison between unsewn and staple anastomosis. We had a significant improvement in the incidence of leakage, and with a relative improvement also in the hospital stay, with no difference in terms of late stricture. So this is our current technique of anastomosis. About pathological results following robotic esophagectomy for all series, they were acceptable with excellent R0 margin status, which was of for all cases R0. A little point about transhiatal mediastinal dissection, which is which has very limited indication for selected patient with relative contraindication to the chest procedure and the anastomosis in the chest. Very briefly, in this setting, the robot can offer a stable view and an improved dexterity to push the dissection up to the mediastinum and providing oncological adequacy. Just to see the dissection can be moved up to the carina with no particular difficulties. Jump to conclusions. Robotic esophagectomy can yield excellent results in terms of blood loss, rates of conversion, and the length of hospital stay, while preserving the adequacy of oncological data. We can yield an acceptable morbidity, which is similar to that of open surgery, and with an intrathoracic look in the setting of Ivor-Lewis esophagectomy, which can be comparable to that of open surgery once the technique of anastomosis is standardized. Obviously, the accurate selection of patients is crucial to limit overall mortality. And thank you very much.
Thank you very much, Dr. Guerra. I would like to know also the robotic esophagectomy results from a tertiary center in the United States. So I invite Stephen Hockwell from Buffalo to give his presentation so we can compare the two tertiary centers, Italy and the United States. Please, Stephen.
My name is Dr. Stephen Hockwald. I'm Chief of GI and Endocrine Surgery at Roswell Park Comprehensive Cancer Center in Buffalo, New York. I really appreciate the invitation. It's my privilege to be speaking about our experience with robot-assisted minimally invasive esophagectomy. And we typically use a side-to-side intrathoracic anastomosis as our predominant modality. I've been performing minimally invasive esophagectomy since 2007, and we've reported our experience along the way many times. This report was from 2016 in 316 patients undergoing laparoscopic and thoracoscopic approaches, with the predominant of patients having a cervical anastomosis that consisted of 77% of our patients. 22% had an intrathoracic anastomosis, and the main method through which we achieved the anastomosis was a stapled side-to-side 6 centimeter linear stapled anastomosis. You can see the results in our patients here. We had a large variety of complications as were expected, with a pneumonia rate of 11.7%. Importantly, our anastomotic leak rate was reasonable at 7.9% for patients undergoing predominantly a cervical anastomosis, and our anastomotic stricture rate was quite low at 4.4%. Our in-hospital mortality was 3 patients, or 1%, with a 30-day mortality of 1.3% and a 90-day mortality of 5%. And the length of stay was on a median of 8 days. You can see just a quick picture demonstrating that we are pulling the stomach and the esophagus out the cervical incision, inserting a 6 centimeter linear stapler, and then closing the common channel with a TA stapler. As many programs have done over time, as they got more comfortable doing minimally invasive approaches, we have switched, as other centers have, to doing predominantly a minimally invasive Ivor-Lewis for esophageal adenocarcinoma with intrathoracic anastomosis. And again, we have done typically a 6 centimeter linear stapled anastomosis. We reported our results in 114 patients in 2019. You can see our pneumonia rates were slightly lower than our previous report at 9.6%, and the anastomotic leak lower as well, from 7.9% to 5.3%. Just a quick picture showing that we're using the side of the stomach with a 6 centimeter linear stapler, and then allows you to use the well-vascularized side of the stomach, and you can excise the tip of the stomach at the end of the procedure. Our median length of stay was 8 days, with a mortality rate at 30 days of 0.9% and a 90-day mortality of 1.8%. And our stricture rate was, again, quite low. And again, I think this is a function of doing a long side-to-side anastomosis in these patients. So why did we switch to robotics? We've done this for over the last 4 years, and there was several reasons. One of the big ones was that we were training surgical oncology fellows that work with us, and we feel that the robotic approach really has advantages for decreasing the learning curve for our trainees. It allows for more precise suturing, as you know, and this leads to less struggles for people learning the technique of minimally invasive esophagectomy. And we also feel it helps the attending surgeons, because teaching the minimally invasive approach over time leads to a lot of wear and tear on our bodies. And in fact, doing the robotic approach has led to much more comfortable positioning and less frustration on behalf of the attending surgeon. So we were thinking of what's the ideal approach doing this robotically, since we've had quite a bit of experience doing this laparoscopically and thoracoscopically. We were deciding whether we really should switch away from our stapled side-to-side anastomosis, which has been our mainstay for minimally invasive esophagectomy. Then we saw results from others who have published leak rates, and this is from the International Registry from 20 centers or 856 patients, showing that leak rates being relatively high for all three of these approaches, but being lowest for the stapled side-to-side anastomosis. And this is the anastomotic method that we have used for our robotic approaches as well. Here's showing a video that we published with our technique. This shows the chest component of the procedure. We typically put 3 robotic ports in the 8th intercostal space. 2 are 8 millimeters and 1 12 millimeter, which is the most anterior port here. And then we also have an assistant port at the bedside, which is typically a 2 to 3 centimeter incision, which allows for removal of the specimen, and the bedside assistant can put in a variety of instruments to allow for retraction of the lung, clips for clipping branches of the thoracic duct when necessary, and for retraction. Our video is shown here. So we typically work from distal to proximal on the esophagus and the right chest, and we're opening the pleura using the vessel sealer. We use a lot of the vessel sealer, mobilizing the esophagus, and then we get a penrose around it, and we're clipping branches from the thoracic duct on the posterior aspect here, and using vessel sealer to divide the periesophageal tissue. You can see a bunch of clips present to ligate branches of the thoracic duct. We don't routinely ligate the thoracic duct, except if we feel that we have a high risk for a leak in patients. You can see the penrose around the esophagus, and we're dissecting on the anterior aspect. Once we mobilize the esophagus, we typically divide the esophagus for patients with adenocarcinoma at the level of the azygous vein. You can see the robotic stapler coming in. We're bringing the stapler from posterior to anterior and dividing the esophagus. The NG tube we make sure is not in the staple line. Then we pull up the gastric conduit together with the specimen, which is sutured to the gastric conduit. We cut the sutures holding the specimen to the gastric conduit. And then we cut off a corner, just a corner of the esophageal staple line. Typically, it's the side of the esophagus that wants to lay next to the gastric conduit that we're bringing up into the chest. We cut off the corner here. This can be done, with the robot, of course, or by the bedside assistant, which is happening here. And then we bring out the NG tube through this opening in the esophageal staple line, as shown here. We then place a full thickness suture. This is a traction suture at this opening. It just allows for pulling on the esophagus. 2/0 silk suture. We spread to make sure there's enough room to get the stapler in there. And then we bring up the gastric conduit to sit alongside the esophagus. Now what you're looking at is the posterior aspect of the gastric conduit that we bring to lie up next to the esophagus, and this gastric conduit is brought up into the apex of the right chest. Bedside assistant can help with the retraction of the lung. And then we're focusing on making the anastomosis to a well-vascularized portion of the stomach. Typically, this is 8 centimeters from the end of the gastric conduit. We make a gastrotomy at a point on the opposite side of the stomach, away from the staple line that's already present on the stomach that was used to fashion the conduit. We make our gastrotomy. We insert the 6 centimeter linear stapler into the stomach and into the esophagus. The bedside assistant can help with rotation of the stomach so that the stomach staple line is resulting again on the opposite side of the stomach, away from the gastric conduit staple line. You can see that happening here. Stomach is being rotated. And we're inserting the entire 6 centimeter stapler. It's been fired. The entry tube is placed through the common channel into the distal stomach. And now what we're doing is suturing the common channel closed. We usually use 3 to 4 sutures to bring the esophagus approximated to the esophagus, and the stomach approximated to the stomach to close the common channel. We have in the past closed it with multiple sutures and left it like that, just with simple suture closure. But now the most common thing we do is we excise this suture line with the stapler, which I'll show you in a second. Again, it's important to get full thickness bites of the esophagus and of the stomach for the closure. And then you can see a stapler being introduced, and we usually use 2 firings of the stapler to excise this common channel. Now we've already created a 6 centimeter anastomosis, so now we're cutting off the lower end of the anastomosis, and we're not worried about narrowing it because we're reducing it from 6 centimeters to maybe 4.5 centimeters, which is quite a lengthy anastomosis, and we're re-excising the end of the esophageal staple line. There it is. So there's the closure of the common channel. We're reinforcing the junction of the linear anastomotic staple line with the other staple line used for closure, just to reinforce it with a silk suture. We put other sutures in to reinforce the anastomosis, including a suture at the apex of the anastomosis here, from the stomach to the esophagus here. And you can see we have redundant stomach at the top, and we excise this redundant and relatively devascularized piece of stomach at the end here. So we're really left with a well-vascularized portion of the stomach for the anastomosis here, and we're also suturing the stomach to the pleura, just to help take the tension off the anastomosis. We're doing an air leak test, so we do an endoscopy and put the anastomosis underwater and make sure there's no bubbles, no air leak. Then we routinely still do this. And then we're using omentum to cover it. So we bring up an abundant amount of omentum into the right chest, and in most patients we can completely wrap the anastomosis with omentum. So for over about a 4-year period, we've done 120 robot cases. 70 have been Ivor Lewis, 8 McEwen, 7 have been transhiatal without any chest incisions, and 35 have been hybrid. So either the chest or the abdomen was done via an open approach and robot use for the other portion of the operation. Our results have been good. We've had no 30-day mortality and a 1% 90-day mortality. We tried to compare our patients undergoing the laparoscopic and thoracoscopic procedure to patients undergoing a robot procedure. So we had our statistician compare 72 patients undergoing laparoscopic and thoracoscopic procedure to 67 patients undergoing the robotic Ivor Lewis. and this data is shown here. The average median age was slightly lower in our robotic cases, but not much. You can see our BMIs in our Western patient population. The vast majority had neoadjuvant therapy in both groups, and the vast majority for adenocarcinoma, 90% approximately in both groups. You can see their clinical stage here with a just slightly higher rate of early stage tumors in patients undergoing robotic Ivor Lewis. You can see the location of the tumor here, where the majority of patients had type 1 or type 2 GE junction cancers in both groups, and a small percentage of patients were distal esophageal adenocarcinoma. The pathological stage is shown here. This is post chemotherapy and radiation treatment, and the nodal yield being slightly higher, but not significantly higher, 20 nodes on median for the robotic approach as compared to 19 nodes with the laparoscopic and thoracoscopic approach. You can see of note that we had significantly less grade 2 complications in patients undergoing the robotic Ivor Lewis, and this were mainly decrease in cardiac arrhythmias. We felt we were basically pushing on the heart less during the robotic cases, which may have led to less arrhythmias after the surgery, plus a slightly reduced rate of pneumonia using the robotic approach. We also had a trend so far for reduced anastomotic leaks using the robotic approach. We've really had only 2 leaks out of the 67 in this group, and about 4 leaks out of 120 patients who've had a robotic approach compared to the anastomotic leak rate of 12.5% in these 72 patients selected for comparison. The median length of stay has gone down from about 8 days to 7 days, which is significantly different using the robotic approach. Now, the operative cost per case we determined was an extra $3,500 US using the robot as compared to our laparoscopic and thoracoscopic approach. But we haven't fully analyzed this, but we would suspect that the slightly reduced length of stay and the lower leak rate with the robotic-assisted approach may lead to reduced overall hospital costs in the long run. Our goal, and we're proud of it, is to try to get toward really close to 0 post-operative mortality. I know we will never be able to get there fully or 100%, but over the last 9 years, we've done about 290 esophagectomies. A minimally invasive approach has been attempted in about 280 of these patients. We've had 0 in-hospital or 30-day mortality for these patients. The robot's been used in the last 120 cases, again, without mortality, and the median length of stay is now down to 7 days. So in summary, the robotic approach has been our main approach for minimally invasive esophagectomy, typically through an Ivor Lewis technique. The leak rate to date for our robotic Ivor Lewis is 3% with a stapled side-to-side anastomosis. The mean length of stay is 7 days, and we feel that the robotic approach has possible clinical benefits compared to the laparoscopic and thoracoscopic approaches. So conclusion, the robotic Ivor Lewis is the procedure of choice for adenocarcinoma of the esophagus. In our opinion, our technique of side-to-side anastomosis is associated with excellent results. We have low leaks and stricture rates. We feel that the robotic approach can be adopted by trainees with a reasonable learning curve. I haven't shown data in this regard, but we certainly feel that there's less attending surgeon fatigue with the use of the robotic approach. I want to thank and give special recognition to my partner, Dr. Moshe Kukar, who's really been the expert in the robotic approach and has got me up to speed over the last few years, has really heavily contributed to our outstanding results. And I want to thank you for your kind attention to this presentation. Thank you very much.
Stephen, thank you very much, because it was really brilliant, very good results. And a question: you do not have any experience with the circular stapler with push string made by the robotic?
We do it on a very rare occasion. If there's not enough gastric conduit and we really have limited gastric conduit to work with and we can't do our stapled side-to-side anastomosis, then we would do the circular staple, the EEA anastomosis, using the Orville technique typically. But again, we do well over 90% of the cases using a 6 centimeter stapled linear side-to-side anastomosis.
It's very, very elegant. And the abdominal part is by robotic or laparoscopically you perform?
When we first started doing the robot 4 years ago, we did a sort of a hybrid. We would do the abdomen maybe open, the chest robotic, or vice versa until we got comfortable. But now, the last many cases, over 70 in a row, have been all robotic abdomen and robotic chest.
So, Stephen, after your presentation, we have to move all to the robotic, I think.
I think it's the procedure of choice, like we say. For the surgeon comfort, obviously, having done many hundred non-robotic, minimally invasive esophagectomies, they're long cases. They're difficult cases. The wear and tear on your body that makes it, adds up over time. So I think the robot allows for more precision, as has been discussed, and also leads to more surgeon comfort.
So thank you really very much for this brilliant presentation. I have to close the discussion because we are late, but thank you also to be connected today.
Thank you, and greetings from New York. Thank you.
Thank you. Bye.
Yeah.
Bye-bye. Bye.
Bye-bye.
So we are 1 hour and 10 minutes late, but I started 1 hour late, so I was on time. I thank you very much again, Ugo Boggi, for this wonderful program, and for the also Fulvio Calise together with Ugo, because I think that the number of updates on robotic is really, really interesting, and I am sure that will be cited in many other articles, helping our journal to increase also the impact factor. So thank you very much to everybody, and I leave for the next session.
Thank you very much. Bye-bye, and thank you very much. Thank you.
Good afternoon. It's a pleasure to take part to this last session, the last but not less important, right? The title of the session is The Future and Beyond. The robot is just already the future, so we are going to talk about the future of the future. And in my mind, can I say a few words? One of the possible advantages of robotic surgery, among others, is just partial resection of some organs, comparing with laparoscopic, and the multivisceral dissection and resection during laparoscopic surgery. So I think we are talking about a very interesting topic, and we will investigate if some results can show these advantages. So I want to introduce one of my friends, which is Laurent Bruno, which is an excellent endocrine and abdominal surgeon. He's a professor of surgery, and he is the chief of the nominal, visceral, and endocrine surgery in the University of Lorraine, Nancy. And his presentation will be about partial adrenalectomy. There is some change about the program because the state of robotic adrenalectomy was actually my topic, but I come after him. So let's go for the presentation by Laurent Dumont.
I would like to thank Dr. Boggi and Dr. Gabriele Materazzi for inviting me to talk about robotic adrenalectomy. I have no conflict of interest, and I have been working in the department since 2 decades ago, doing robotic cases in all fields of the general surgery and digestive surgery. This talk is based on an experience of 2 decades in endocrine surgery, including adrenal, thyroid, parathyroid, and endocrine pancreas. What is robotic surgery? You still have a patient in the middle of the room. You have a robotic cart with 3 or 4 arms, and those arms are telemanipulated by the surgeon at the console. And as you can see in the red square, you have a computer between the patient and the surgeon. And actually, this computer gives you 3D perception, improved dexterity, improved ergonomics. And we believe that consequently, the robotic surgery is not a new approach. It's rather a logical evolution from conventional laparoscopy. And the question is, we as surgeons are the last specialists having used the computer to improve the care we provide to patients. And the question is, why should we be the last ones? Cardiologists have done that for years, radiotherapists, etc. So there is no reason that surgeons do not try to improve the care they provide to patients using a computer. For adrenalectomy, you have a regular clinical situation and challenging situation, more difficult phases. It could be for the patient and it could be for the surgeon. Everything should be simple for adrenals. On the right side, you have a small gland, not always the case, but a small vein about 1 centimeter in length, and in the left part, one main adrenal vein of about 2.5 centimeter. The surgical procedure is pretty straightforward. On the right side, you dissect the main vein, you put 1 clip, a second clip, and you cut between the 2 clips, and that's it. The operation is almost done. When you look at post-operative complication meta-analysis in laparoscopic adrenalectomy, you observe that operative time range from 1 hour to 4 hours, conversion rate from 0 to 4%, morbidity rate from 0 to 16%, and length of stay from 1 to 6 days. Most of the complication rates range from 5 to 10%, and most of the complications are not very severe. They are Clavien-Dindo 1 or 2, and very few of them need a reoperation. When you look at data coming from a national database in the US, you observe that conversion rate to open is about 3%, 2.9%. Complication rate, any complication, is 6.7%. And the need for a stay in hospital more than 48 hours in about 18% of patients. It's about the same data we have in Eurocrine database in Europe. So the question is, with the robot, with using the robot, is it possible to do better? Is it possible to do whiter than 1? And as surgeon, we should always remain sensitive to new developments, because the history of the surgical profession that we have is nothing more than a series of innovations that have survived the test of time and evaluation. This is the paper we published with including the first 300 patients. Mean tumor size 3.5 centimeter, mean operative time 1 hour and 28 minutes, and most of the patients had hyperaldosteronism or pheochromocytoma. You have here the complication rate, 21 patients, 6.9%, and most of the complications are not severe, Clavien-Dindo 1 or 2, as you can see on the left part of the diagram. On the right part, you have 3 patients needed a reoperation, 1 for complicated incisional hernia, one for splenic trauma and one for ischemic mesenteric ischemia. Conversion rate, 9 patients out of 300, 2.9%. And you have here the causes for those conversion, 4 for adhesiolysis, 3 for intraoperative bleedings, and 1 for the need of lymphadenectomy. Operative time. Why we are looking at operative time? It's because operative time is a clear surrogate marker for surgical difficulties. These have clearly been shown by Aaron Berber from a Cleveland clinic 20 years ago. So we did that in the robotic group, and we observed that during the first 100 patients, we observed a slight decrease, a regular decrease over time. However, we observed 3 independent predictors of operative time, which were surgeon expertise, first assistant level, and tumor size. So the question is, do we have to control this parameter in comparative study, comparing robotic versus laparoscopic adrenalectomy? We believe, and I believe, that the answer to that question is yes, because otherwise the risk is to include those parameters in the comparison, and you have here an issue, a problem with the quality of the comparison. We did that case control. We observed similar mean operative time. We observed similar mobility rates, and we observed a slight decrease in mean hospital stay in the robotic group. But globally, we concluded that the perioperative outcomes were similar between the 2 groups of the patients. I put here the most recent meta-analysis regarding laparoscopic versus robotic adrenalectomy, and this paper concluded that even though robotic adrenalectomy and laparoscopic adrenalectomy were equivalent regarding perioperative safety, robotic adrenalectomy was associated with a favorable length of stay. This is the same data we had with our own comparison. And this also made us submit this abstract in 2016, concluding that these data do not support the hypothesis that the robotic system may improve perioperative outcomes in comparison with conventional laparoscopic approach. If this is going to change, maybe, this is an ongoing paper managed by Özer Mackay from Izmir, Turkey. He included more than 800 patients with laparoscopic adrenalectomy versus about 200 with robotic adrenalectomy. He compared complication, any type, and he observed a significant decrease in the robotic group, 1.5% versus 16%. Most of the complications are grade 1, and he observed also a decrease in the length of stay, 2.2 days versus 3.8 days. We have the same data with Eurocrime. What is next? We believe that in challenging situations, large tumor, pheochromocytoma, partial adrenalectomy, the robotic system may be more appropriate in those more difficult situations. For larger tumor, I'm going to talk about exposition, stapler, clamping, and conversion. For large tumor, one of the tips is to mobilize the tumor, especially on the right side. When you cannot access directly to the vena, retrohepatic vena cava, you first mobilize the tumor, even if it's a pheochromocytoma, and you dissect, trying to do a clockwise rotation of the tumor. This allows you to access to the right aspect of the vena cava. You control one by one all the small veins that you have between the tumor and between the vena cava. And this takes some time, but it has to be done. And then you finished the dissection with the clockwise rotation of the tumor, and you have completed the operation. You have the operative field with all the small veins you have controlled and clamped for this large pheochromocytoma. So first point, exposition. Second point, use of stapling. In this case of metastasis, you can see that there is some adhesion between the metastasis and the vena, the retrohepatic vena cava. And you can see that the situation is a bit complicated because you have inflammatory aspect of the dissection. For the sake of time, you do not have the whole video, but you have first to control the upper part of the vein and the tumor before applying that stapler. But this stapler allows you to control and cut the vein, even if the vein is large, too large for applying a clip, and you finish with the section using the scissors and finish the adrenalectomy, as you can see here. Clamping, third part, I have no video for that, but you can use small clamp to control the vein and then do your suture. It's possible to do also a thrombectomy, as in this case report. Conversion, you can see in this patient with a large pheochromocytoma, 12 centimeter. You start the dissection, as we just discussed, with the dissection between the tumor and the kidney to improve the exploration. And you can see that it's not easy to control the vein. The vein is large. So at that time, we had not decided whether to use a clip or a stapler, but the situation got worse. We tried to control the bleeding, which was not efficient enough, I would say. Then we tried to use the clamp, and the situation was not easier. So we decided with my friend, who is a vascular surgeon, to control the situation and to do a conversion and to finish the operation in good condition, which we did. So for summary, for large tumor, improve exposition, use stapler, clamp suturing, and decide early when you need to convert. Anticipate the situation with a vascular surgeon or without if you don't need it, but anticipate the situation, and it is never a mistake to convert. Pheochromocytoma, you have large tumor, hemodynamic issue. What are hemodynamic issue? You have an hypertensive phase between adrenal vein clamping, and after vein clamping, you have hypotensive phase. The first point is, do we need to normalize blood pressure before adrenalectomy in order to improve intraoperative hemodynamic instability and perioperative complications? Recent data have clearly shown that the blood pressure normalization after preoperative medical preparation had no significant impact on intraoperative hemodynamic instability and perioperative complication. As you can see in this diagram, the red line is the pre-induction mean arterial pressure, and the blue dots are the maximal systolic blood pressure observed during the operation. You can see that you have no relation between the two. And the second point is the comparison that we did. It's not published yet, but we did a head-to-head comparison between the robotic adrenectomy for pheo and the laparoscopic adrenectomy for pheo. So the robotic is in red and the laparoscopic is in blue. You can see that in the robotic group, the maximum systolic blood pressure was lower in comparison with the laparoscopic group. And similarly, the minimum systolic blood pressure was higher than in the laparoscopic group. So globally, it means that the range between the maximal systolic blood pressure and the minimal systolic blood pressure is lower, is less important, less intense, or less severe in the robotic group. Paragon glioma, we believe that the robotic system extends the feasibility. Those tumors are most of them benign, are less than 10 centimeters in diameter. You have here one example of a retrocaval paragon glioma and a paragon glioma within the right renal pedicle. And this has to be validated by further study, but our impression is that the robotic system is a good option for those tumors. Partial adrenalectomy, the goal is to avoid hypocortisolism by leaving normal adrenal tissue. And 2 points here, two potential problems. It's feasible when you have a small tumor and the threshold could be 3 centimeters, and it's sometimes difficult to locate the tumor within the gland, and you can get some help using the indocyanine green fluorescence. And this example actually is an ideal case. You have one small NF1 pheochromocytoma 1 centimeter in diameter, very well located, so well below the 3 centimeter in diameter threshold we just talked about earlier. And you have no problem to locate the tumor within the gland, and you can do this operation, but it's not always the case. So can we see the future? Of course not, otherwise I would be rich likely. We believe that the robotic surgery for adrenalectomy is in the middle of its evaluation process between exploration and assessment. One of the drawbacks is cost. Globally, the robotic system costs 2.3 times more than the laparoscopic approach for performing an adrenalectomy, even if you have some means to decrease this difference in cost by reducing the operative time, by increasing the number of cases per year, and by using the year depreciation. But the remaining question, globally the robot doubled the cost, and the remaining question is what benefit and at what cost. Drawback, medical legal issue. What happens if you have a lawsuit after a robotic procedure? It was more obvious 10 years ago, I would say, and in 2021, with the spreading of the number of the robot, I think this threat is less important, but it's maybe my own opinion only. We need quality control for clinical evaluation, and we need rigorous evaluation using prospective control chart and rigorous evaluation for comparing robotic versus conventional laparoscopic adrenalectomy. In conclusion, for the patient, there is likely no difference between the two, laparoscopic adrenalectomy versus robotic. It's about the same for them. For the surgeon, in regular situation, it's about similar, but I do believe, but it remains to be validated that in more difficult situation, as we saw, big tumor, pheochromocytoma, that the robotic system could be helpful. This remains to be validated. There is likely a niche depending on patient, surgeon, and healthcare system. It's also depending on country and local settings. I do believe that the concept of laparoscopic and computer will survive, and we should not be dogmatic and stay open for the robotic approach. When you look at paper, it's always increasing years after years. The future depends on what we do in the present. And I will leave you with this last slide because actually the surgical innovation spreading has already been modelized. What you need is a certain patient demand with a threshold of about 10%, a moderate cost to learn and to do the innovation. It's not the same to learn how to do an adrenalectomy using the robot versus doing a thyroidectomy, which is more complicated to my mind. And you need an aggressive promotion from the company. And what you need is a positive perception from all those three parties, patient, surgeon, and company, and that's all. You do not need any randomized prospective controlled trial. So I thank you very much for your attention. I would be very happy to answer any question regarding robotic adrenalectomy. Thank you very much.
Professor Bruno is not connected with us, so we thank him about this exhaustive lecture. And we go on, right?
Yes, we move on. We move to the next presentation by Dr. Piccoli. She's a surgeon. She's an experienced surgeon, very skilled with robot, and she will speak us about something that was at least considered very difficult with the previous generation of robot, and now maybe is more easy to perform, but she will speak as if it is also useful to do. She will speak about the robotic multivisceral resections. Please, Dr. Piccoli.
First of all, many thanks to Professor Boggi and Professor Calisi for the involvement in this journey and also in the volume of updates of surgery. And first, we have to speak about the possibility to use robot for multi-visceral resection. You know that the robotic platform was conceived also to use in multi-organ approach and multi-visceral approach, multi-visceral resection, and also multidisciplinary approach. But the robotic multi-visceral resection is not so diffused and not so well documented in literature because only few papers about this opportunity. But why a multi-visceral approach? First of all, for synchronous tumor, you know that the advances in diagnostics and imaging technologies allowed to detect the synchronous tumor, especially using MRI for rectal cancer, that incremented the diagnosis of synchronous prostate cancer, but not only in this field. And overall, the frequency of multiple primaries is reported in the range of 2–70%, and the incidence of synchronous renal and colorectal cancer has been variously reported with percentage ranging from 0.4% to 4.85%. And synchronous rectal and prostate cancer is about 1%. But not only synchronous tumor, also synchronous pathologies, benign and malignant, and then also metastatic tumors. What means combined approach? It's not so easy to approach because the removal of both lesions at the same time with a single procedure needs a very good tumor board discussion, a very careful evaluation of the patient's in tumors characteristics, because you need to evaluate if it's possible to do a longer procedures than 2 different procedures. And also very important to perform a multi-team planning in the operating room, because you need nurses, anesthesiologists, and also 2 different teams. And also if it's possible to do a mini-invasive approach for both pathologies. What are the advantages of a combined approach? Obviously, shorter length of hospital stay, because you need only 1 recovery. And also you can reduce the post-operative morbidity. And if you need to do an adjuvant chemotherapy, you can do earlier because you treat both pathologies in the same time. But you can do different kind of combined approach, because you can do totally laparoscopically, or hybrid laparoscopic and robotic, or full robotic. And the majority of hybrid approach are reported about laparoscopic colorectal resection and robotic prostatectomy. Why? Because sometimes we have a very good consolidated robotic experience prostatectomy, not so good in general surgery, in robotic general surgery. What about full robotic approach? It needs a multi-organ robotic approach is gaining interest from surgeons worldwide, you know. And I think that combines the benefit of minimal invasive surgery with the technical advantages of the robotic platform over standard laparoscopy. This was the largest series reported in the literature about a full robotic approach for metastatic tumor by Navarro and Min. You know, only 12 patients that underwent robotic simultaneous colorectal and liver resection for colorectal with the liver metastasis. Why the choice to treat both these pathologies? Because the complexity of liver resection. So the robotic approach was preferred over laparoscopy in more complex cases, such as bilobar tumor involvement or unfavorable segment location, like 1, 7, and 8. And colorectal resection was performed at the first step in all procedures. Overall morbidity not about 41%, but only 2 major complications, one leak in laparoscopic anterior rectal resection, or a one liver abscess in a right hepatectomy. So the conclusion of this report was that simultaneous robotic surgery of colorectal neoplasm with synchronous liver metastasis can be performed with acceptable morbidity, but with careful patient selection when performed in specialized center with well-trained teams, even in case requiring major liver resection. So careful selection, but also specialized center in both treatment. This is the largest series published about full robotic approach in synchronous tumor, not metastatic, but synchronous. 10 cases, all performed with Da Vinci Xi, with also table motion, integrate table motion, and full robotic approach without conversion, without the necessity to use an end-assisted laparoscopy or laparotomy, no post-operative complication, and also a median hospital stay of 6 days. And in 3 cases, it's possible to use also a table motion. You say generally right colectomy and sigmoid resection, right colectomy, gastrectomy, anterior resection, enucleation, and endocrine tumor of the tail, and also generally colon resection associated with other operation. What about our experience till now? From January 2018 to May 2021, we performed 14 cases with a full robotic combined multivisceral resection, 12 with Da Vinci Si and 2 with the last Da Vinci Xi. And we involved general surgeons, urologists, and gynecologists. We published only 2 papers, one about the first cases of combined full robotic partial nephrectomy and colorectal resection, and in the updates in surgery, the experience of a full robotic multivisceral resection, the modern experience also with the review of the literature. What are the results? 11 multivisceral full robotic resection with the Da Vinci Si, and we excluded the T4 neoplasm, hybrid procedures, laparoscopic, endoscopic, and robotic, and if the only associated procedures was only a robotic cholecystectomy. Prior abdominal surgery was not considered an exclusion criteria. So we had 4 patients with synchronous tumor. You see generally colon cancer and renal cancer, and that could be in the same side, also in different side. But we treated also 4 patients with the cancer associated with benign condition, and also 3 cases of deep infiltrating endometriosis that required or appendectomy, rectal shaving, or sigmoid discal resection, and anterior rectal resection. What are the results? Yes, yeah. For only an example of what means to do a multidisciplinary resection. This is a clinical case, 59 years old woman. What is the history? Patients presented with blue rectum, colonoscopy, and adenocarcinoma at about 15 centimeters from the anal verge, and the CT scan, a 5 centimeter solid lesion in the upper third of the left kidney, strongly suspicion for malignancies. So, tumor board decision, concurrent robotic anterior resection combined with robotic partial left nephrectomy. Oops, what happened? Okay. So this is the position of the patient. Very easy anti-resection because not so obese patients, as you see. So very easy dissection of the plane. We started with the anterior resection. This is the tunnel under the splenic vein to detect exactly the right plane. So the splenic flexure mobilization. At the beginning, we used only the arm 1 and arm 3 and the camera without using the arm 2. And the arm 2 is used only to do the pelvic step. This is the section of the inferior mesenteric vein, then the vessels, then we go down and we perform a normal robotic rectal resection. I think that we can go because it's late for all of us. And then after we perform a right left partial nephrectomy, in this case with a right lateral decubitus and with a ischemia of the clamping the renal artery for about 25 minutes. And then we perform the removal of the kidney tumor. So you see the operative time. The patient was discharged on 10 post-operative day. Post-operative course uneventful. And the pathology was a rectal cancer, T3 and 0, and the kidney papillary tumor, low grade. You see the partial nephrectomy and then the definite treatment. So this is our experience results. We had only 2 complications, 2 anastomotic leak after the 2 anterior resection, robotic resection, 1 combined with right partial nephrectomy and 1 performed during endometriosis-related surgical procedures, but both cases needed only a laparoscopic reparation for to fashion a loopy ileostomy combined with endoscopic local treatment of the leak. No conversion, no intraoperative complication, at least. So, what are the conclusions? We think that combined multiple organ surgeries with the full robotic technique are safe and produce oncological adequate results in the hand of experienced team. These represent the first reports of full robotic partial nephrectomy combined with robotic colon rectal procedures. But the multi-team surgical pre-planning is the key point for the success of the operation. And advanced in technologies like integrated table motion, Da Vinci SP, Firefly could help reducing operative times. And the technical feasibility of the procedures, also due to technological advancements, should not overshadow the risk of combining 2 major surgeries in frail patients. So we need an experienced team capable to evaluate each case and to manage possible complication that is the real aim that we have to do. Optimization of the resources is essential in the modern management of healthcare facilities, and multidisciplinary use of the same platform fully applies to this logic. And in the end, the focus of this study is not to standardize a technique, because it's possible to use there is a very heterogeneity of the treatment of the pathologies, but perhaps standardize a method to treat with a multidisciplinary approach different tumors and different patients. Thank you very much.
Thank you, Michaela. Question will be at the end of the session. Thank you so much. And now we go for the last presentation. So it's a pleasure to introduce Gabriele Naldini. And Gabriele Naldini is the chief of the proctological and perineal unit in the hospital of Pisa. He has a very great experience in this kind of surgery and also in robotic approach for this kind of surgery. So he will speak about advantages of robotic surgery in the treatment of multi-compartmental pelvic organs prolapse. Thank you.
Thank you very much, Gabriele, and thank you to Professor Calise and Professor Boggi for your kind invitation. Today I'm going to speak about advances of robotic surgery in the treatment of multi-compartment pelvic organ prolapse. So it's around 10 years, and after 8 years of work with a pelvic floor multidisciplinary team, we published a complex pelvic organ prolapse decision-making algorithm. You see that is really complex because we have a lot of possibility, a lot of different patients. And so we need to know all the technique that we can use to do this. And as we pointed out in our paper on decision-making algorithm, being a pathology with patients, symptoms, and anatomical situation very heterogeneous, who does only one or two type of procedure, thinking that they are miraculous, will be a loser. So we must know all the procedure to choose the right procedure for the right patients. So if the selection criteria are influenced by the availability of alternatives, if I can do pelvic floor rehabilitation, ventriculotomy, colpoproctosacropexy, colposacropexy, post-lateral suspension, internal lung, star, transvaginal, transperineal levatoplasty, sacral neuromodulation, surely my selection criteria will be more precise. Which are the advantages of abdominal approach? Because you know that the proctologist or the colorectal surgeon or the gynecologist may have abdominal approach or transperineal, transanal, transvaginal approach. Possibility to easily correct a multi-compartmental defect, possibility to correct the continent disorders as well, and ability to reduce complication, but this is not demonstrated as at the moment from the abdominal approach. Disadvantages, technically difficult because we have to work in the pelvis and sometimes could be very difficult, especially for not high-level laparoscopic surgeon, okay? Possibility or more need to correct multi-compartmental defect, but are we all capable to do this? And the potential less effective on ODS symptoms. We know that, we heard today, the learning curve is shorter. I am absolutely agree. And we have some advantages, especially for this kind of surgery, and you can operate better in a confined space, and you can do the procedure with greater accuracy and comfort. For example, it's easy to arrive on the promontorium fascia without any kind of problem and avoiding any kind of injuries. And especially, it's easy to arrive deeply in the rectum, close to perineal body, to be able to correct also the third level of the lens that is really important, especially for ODS. And the most important thing, in my opinion, in this kind of operation is that it is easier to suture. And also on the promontory, we try to don't use the tack, but we use always stitches because the first problem of the recurrence is the detachment from the promontory. And especially because we do always, more or less always, mesh procedure, is really easy to put the mesh with great accuracy and with a great final satisfaction. So we start, it's natural that is a very specialized indication, but we go to see which are the operation that we can do. If we have internal rectal prolapse with L-rectocele, with associated with enterocele and vaginal posterior wall prolapse, with or without imparadenal continence, what we do is a ventriculotomy with or without vaginal wall suspension. What the problem of this kind of operation that in literature the ventriculopaths have very poor results about obstructed defecation syndrome. The main problem is the low supraperineal rectal seal. Is for that we try to do a deep ventriculopaths arriving close to the perineal body. This is the procedure. Like before, we arrive on the promontory fascia, then we open anteriously, we go close to the perineal body, then we fix the mesh. At the moment we are using titanized mesh, and you can see that we can be very accurate in the stitching and the position of the mesh. Then we folded the mesh, and thanks to the Da Vinci, it's difficult to do laparoscopically. We can put stitches also on the posterior wall of the vagina. This is to share the traction not only to the apex of the vagina, but to all the vagina, so we can have better resolution of the colposil. That is one problem that we can have after this kind of procedure. And more, we can give two different tension to the rectum and to the vagina, and we try to allow the sliding between the rectum and the vagina, because if you put together, if you fix the rectum, mesh and vagina together, you have not anymore the sliding between rectum and vagina. If we have internal rectal prolapse with rectal seal plus vaginal vault prolapse and enterocele, with or without imparted continence, colpoproctosacropexy. So the first step is like before, is a normal ventriculopaths. Then we fix, in this case, the apex of the vagina, but to correct also the cystocele and the vaginal vault prolapse, we fold the mesh and we fix also the anterior part of the vagina, and pushing also on the cystocele and correct also the cystocele. If we have internal rectal prolapse with symptomatic hysterocele and symptomatic cystocele, what we can do is pop abdominal lateral suspension, that is the Dubuisson technique, associated or not with star or internal Delorme. This is the POPs. Now we are doing the space between vagina and bladder. Then we prepare the two passage under the peritoneum. So we fix the mesh to anterior wall of the vagina and to the uterine cervix, and then we use this technique to suspend the anterior wall of the abdomen, the uterus. If we have symptomatic hysterocele with internal rectal prolapse, with or without rectocele, what we do is abdominal supracervical hysterectomy and colpoproctosacropexy. The first step are the supracervical hysterectomy. I'm very happy to have a strong collaboration with Professor Simoncini, that is young, not so young, he's 50, but he's a very strong gynecologist, a very open-minded gynecologist. So we put a lot, we do a lot of procedure together. And you see, the first step is the supracervical hysterectomy. We prepare the space between the uterine cervix and the bladder to be able to treat also the cystocele. We close the cervix. Then we do the rectopexy. I want to underline that most of this video, the first operator was my young assistant. I have two assistants that are able to do, because of the learning curve, the procedure probably better than me. Okay, now we fix the rectum. This is the preparation of the rectum. We try to arrive deeply, as deeply as possible. You see that the mesh is always well positioned. Okay, then we fold and we push some stitch on the cervix, and then we fix to anterior wall of the vagina. Okay, then thanks to the kind of invitation of Professor Calise, we published this our experience from September to 2014, December 2018 in our with our collaboration in this clinical center. We have more than 220 women that underwent robotic surgery, and the procedure that we took in consideration was robotic ventriculorectopexy, robotic ventriculorectopexy with folded mesh, robotic abdominal corpus sacropexy, and robotic assisted lateral suspension. With robotic ventriculorectopexy, we have an improvement of resolution of ODS more than 80 and improvement of vaginal bulge more than 90. With the use of folded mesh that we move after 3 years, we have another improvement of ODS around 85%, and also the vaginal bulge was solved in more than 95% of patients. With robotic abdominal corpus sacropexy, we have an improvement of 98% of vaginal bulge and 95% of problem of urinary incontinence. And the last, the lateral suspension, the Duboisson technique. We solved the vaginal bulge syndrome in around 88% of patients, and urinary urges disappear in around 90% of patients. Complication, we have no conversion and not robot related complication. Zero dislocation of the mesh. We have one hematoma of rectovaginal space, but treated conservative. 2 lateral arms mesh mobilization was necessary because of the pain after lateral suspension, and 1 anterior vaginal wall exposure. What say Professor Simoncini, he wrote in 2016, some steps of robotic treatment of complex pelvic organ prolapse are easier, and this may result in less morbidity, fewer conversion to open surgery, and better results than laparoscopic approach. Then we have my personal consideration, but what I want to underline that probably, especially for some kind of complication that we have, especially for mesh erosion. You know that we in pelvic floor we have a lot of problem we had, or somebody had, especially for transvaginal mesh use, a lot of mesh erosion. But actually in literature there is no one complication due to mesh erosion in procedure made by robotic approach. So, which are the results? High quality surgery available for a greater number of surgeons. We must keep in mind that at the moment, most of the pelvic floor surgery is performed by gynecologists who are not always happy to surgically handle the rectum, and as the colorectal, probably less, are not comfortable to handle vaginal or bladder. The short learning curve, the complete control of procedure, and improve efficacy of the and performance may reduce the surgical barrier of this not easy procedure. So, which are the results? No more transvaginal or transanal, transperineal approach due to difficulty or inability to perform abdominal surgery. We know, especially for gynecologists, that most of the gynecologists prefer to do transvaginal surgery because they are not comfortable in abdominal surgery. So the best procedure for the right patient without technical limitation. In a time when we talk about economic sustainability, I think that the possibility of having a greater number of surgeons who can do complex operation with the same quality of the top surgeon can also be transformed in economic advantages. So how do I feel when I'm doing pelvic floor surgery? I feel like I'm really doing what I want to do in the way I want to do and not what I can do. Science says this is a complex surgery where we perform anatomical surgery to improve functional symptoms. I think that the more accurate and precise we will be in the technique, the better results will be for our patient. And above all, who wouldn't want to have a robotic technology to do this kind of surgery? Thank you very much.
We can open the discussion. Is there any question from the floor? I have one for Dr. Piccoli. What are your expectations for the next generation of robot in terms to improve the multivisceral resections? What would you like to have to improve this kind of surgery?
So, for example, also the ESP could be a very advantage because you need now sometimes the port that we use for one operation is not the best for the second operation, and then we have to add 1, 2, or 3 more ports. If you have the possibility to use one with the possibility to introduce the same instruments, I think that could be an advantage. And also the table motion, the integrated table motion, I think that it's very important because you can move independently from the operation, so you can spare time. Because the problem of multivisceral and multi-organ surgery is the time that you spend between the 2 different procedures to prepare again the operative table, the operative camera, all. So not the operation, but what you need to do better different times. So I think that all the improvement of technology is improve the sparing time.
A question for Gabriele, because thank you for your very nice presentation, very nice operations, and we understand from your speech that you prefer robot doing this kind of operations.
Definitely.
And you explained why. My question is, but there is a type of patient in whom you would prefer, you really would prefer the robot, and I mean BMI or body conformation, you know.
Yes.
Can we make a selection if you would choose one patient in whom you prefer to use robot?
It's natural that probably is the high BMI, but you take in consideration that if we have a high BMI, we don't do this kind of procedure because if we have a high BMI,
You have also, if you can treat what you want, you can pull up what you want. But if she is obese, your functional results will be very poor. So we have to select the patients. It's not possible to select a patient with a high BMI and thinking that you can solve the constipation problem of the uterine problems is really difficult. So what I think is that for me, that I'm not a very skilled surgeon, but I don't know how many surgeons are able with laparoscopy to do to make the stitching in the rectum in a proper way. I should prefer always to have this operation because we are treating benign disease, and we have to. Our goal is to improve not only anatomy but functional results. So this is the problem why we need to have very high level of surgery in this field.
So Gabriele, it's time to close the session. But before closing, I would like to call at the podium Ugo and Fulvio to give us the very last take-home messages.
Oh, parliamo inglese. Non ne posso più. Well, the first challenge that we have faced is to hold this Congress in the first weekend liberi tutti. And as you know, some of us have been freed themselves in advance, but that's okay. Naturally, I want to thank you who have resisted to the fascination of this beautiful city, and also all the ones that have contributed to this. The second challenge is that for the first time, maybe, or one of the first time, this is a complete Congress in English. I don't know whether this is we may be proud of this or not, but anyway, unfortunately or not, the official language for writing, medical writing, is English. And it's not easy also to handle all these papers and all these talks speaking in English. So thank you for your comprehension. And the third and last one is the fact that for the first time, maybe, we have talked about something that has been written. Verba volant scripta manent. What you have heard today has been validated by the peer review updates in surgery. And also for this, I thank all of them that have made such a fantastic work. And in the end, I thank it on behalf of Ugo, naturally, all his team, and Fabio Vistoli, first of all, for having made possible to realize this little step in our, let me say, in our country, and also this important step for our official journal that pretends to be the Journal of the Italian Surgery. I hope that all of you, and if there is someone still listening to us, will believe in this, because we need to represent the beautiful work that we do in our clinical practice, and not always we do as well as we do nelle nostre corsie. Così, grazie a tutti e un abbraccio.
Just to conclude by saying thank you to Fulvio, because I have to say that Fulvio is really the engine of updates, for sure. It was the engine of the monographic issue and also of this meeting. So thank you, Fulvio. And I think my thank you should be the thank you of the Italian Surgical Society and all Italian surgeons for what you did in the last few years, but I believe that they were very intense for what you did for all of us. So thank you, Fulvio. And also today I have to thank you, all of you, those who have already left and those who were really brave to stay here until 6 o'clock on a Saturday evening. And to my good friend, Fabio Vistoli, who did so much. I want to go into the details of what he did today, but he did really a lot, and it's thanks to him he were able to be connected worldwide. He just said that there are still other brave people connected with us from all over the world, so this is also additional good news. So thank you, Fulvio, thank you, Fabio, thank you, all of you, and enjoy the rest of this Saturday evening in Pisa. Thank you.
One last thank you to Barbara, Evinco, and his group. It's due. Thank you again.